Check. Hello. Check. Hello. Hello. Hello.
First of all, I am going to invite on stage our respected chairpersons. First is Professor Dr. Ronin Dasgupta sir. He has been the ex-head in the Department of Endocrinology, NRS Medical College, Kolkata. And also Dr. K.D. Modi sir from Hyderabad. He has been the consultant in Care Hospital with more than 100 papers and has have been guide for numerous students and also received a lot of accolades.
Hello. Work. Good morning to all. And to begin with, we thought without any delay, we'll start the session. And we have today Dr. Anuja Dokras. She is, from her CV, it seems that her entire life is dedicated to PCOS and reproductive gynecology. She is Executive Director, Women's Health Center for Clinical Innovation and Department of Gynae and Obstetric. She is also Director of Penn PCOS Center and Professor of OBG in University of Pennsylvania. She is Executive Director of Endogenous Access PCOS Society US, Founder Professor in Women's Health, University of Pennsylvania, and she is Associate Editor of Endocrine Review and ex-Associate Editor of JCM prestigious journals. So Dr. Anuja will focus on PCOS and cardiovascular health, and I request Dr. Das Gupta to say something about in context of the topic.
We are most happy today because Professor Dr. Anuja Doctors, who is a great professor working in PCOS or reproductive endocrinology. She is among us and will deliver her lecture on cardiometabolic risk and ASCVD in PCOS. I invite Dr. Dokras to please deliver your lecture.
Good morning, everyone. Thank you so much for that introduction. Yeah, my slides are up there. So what I thought I'd do today is focus a little bit on long-term management of PCOS, and cardiovascular disease risk becomes a very important aspect of that. These are my disclosures. So we'll first discuss why PCOS is considered as a risk-enhancing factor for cardiovascular disease, and then actually show you the evidence and the data that supports this association. That is it just what we know, diabetes, obesity are the risk factors, or PCOS itself is an independent risk factor? And then finally, we can end with what about the pathophysiology of PCOS leads to this increased risk of ASCVD. So I think from an endocrinologist's point of view, you know that this is a long-term chronic condition. These are not women who have a gynecologic issue for a short period of time, and then we don't need to follow them. In fact, we are making the diagnosis pretty early. We have pediatric endocrinologists in the audience as well. And typically, we make the diagnosis in the early teenage years, late teenage years, early 20s. They may have the typical presentation of irregular menses, hirsutism, some weight gain. And then with the first sort of line of management, be it birth control pills or metformin, weight management, over that second and third decade of life, as we follow these patients, they still present with risk factors. The weight goes up, there's some pre-diabetes, and then they come and ask us about the fertility counseling. And then again, as we follow them towards menopause and perimenopause, we find that the gynecologic issue gets better. Their menses are now more regular, the androgens drop, but they might have had a history of gestational diabetes in their pregnancy. Now there's dyslipidemia. So really this has to be considered as a chronic lifelong condition, and how do we address this at a very early age? So over the last 3 decades, we know that there are a number of risk factors, as you can see up on the slide, that are increasing the risk for cardiovascular disease in this population. Number of studies have shown evidence of subclinical atherosclerosis as well in this population. But the main question we have all been asking is, are these women truly at risk for cardiovascular disease? Are we seeing the MIs and the strokes in this population? Or they have the risk factors, but it doesn't ultimately result in an increased risk? And my group has tried to address that question by doing studies that have focused initially on metabolic syndrome, where, as you all know, it's a number of risk factors put together, and hence it's a good surrogate marker. And then metabolic syndrome leads to the increased risk of diabetes and heart disease anyway. So that has been our model, and I'm going to show you a lot of our research studies that build that evidence for increase in cardiometabolic risk. So this was our very initial study almost 20 years ago, and we titled it that all women with PCOS should be screened for metabolic syndrome. And what did our evidence show? That early on we found that not only was the risk of metabolic syndrome high in PCOS, when we looked at this group of under 30, so relatively young women have an increased risk. It starts pretty early, and over time, a number of groups around the world have shown this. Similar data and I think there's data from India as well, showing this increased risk in the 20s. So the question is, why? Why do women and what is driving this risk at such a young age? So as you know, the diagnosis of PCOS is based on the Rotterdam criteria. And when we do this, 2 out of 3 criteria, we get the phenotypes A, B, and C. These are all the hyperandrogenic phenotypes. And again, this is one of our very earliest studies. I have pictures of all our trainees who are the first authors, just to give them credit for all the work they've done. So what you see here is the hyperandrogenic phenotypes, A, B, C, are the ones that have that increased risk of PCOS, more than the phenotype D that does not have the elevated androgens. The second question we asked is, are there differences across ethnicities and continents? So we had this international group of patients that were contributed by different researchers. The Indian group came from Bhubaneswar, from Dr. Sujata Kar. And then the reference population is the US white population. And as you can see, relatively high risk, the background rate is usually 8 to 10%. So relatively high risk of metabolic syndrome across all nations and continents and ethnicities. But what differs is the components. So for example, in the black population in the US, it's the blood pressure that's usually higher. In the Indian population, as you all know, it's the increase in the fasting glucose or the triglycerides. So the components are different, and our counseling will vary, but overall it's contributing to a similar elevated risk. And then we said, okay, the risk is high at 20. What happens as we follow these patients? So in the US, in the Penn PCOS Center that I direct, we have a cohort of women we've been following for almost about 15 years now. The average is about 7 years. So as we followed them over time, the red is the black population, the white population is in blue, and that risk persists. They come to see us, they're on medications, controlled for age. Despite those interventions, there is an elevated prevalence of metabolic syndrome. And when we ask the question why, what is driving this risk, the main indicator is BMI. And then as we had suspected with the phenotypes, there's an increase in both the free and the total testosterone as a driver. So that hyperandrogenism in the pathophysiology seems to be an important driver of cardiometabolic risk. So I've shown you all the evidence, especially from my group, that the risk of metabolic syndrome is increased. Is the arrow showing up? I don't see it on the screen. Can you see an arrow? Because I've been pointing, but that's okay. So the metabolic syndrome, obesity, diabetes, and impaired glucose tolerance. Okay, there, that one's showing up. So it's no surprise that once they're pregnant, these women are also at an increased risk. And that risk is going to be preeclampsia and gestational diabetes. And it's important that we counsel these patients about that risk. And in the postpartum period, which is sort of now considered as the 4th trimester of pregnancy, these women also have an increased risk of preeclampsia, eclampsia, and hypertensive disease. This is our study with over 42,000 women with PCOS. And what we showed was that they have a high risk of postpartum preeclampsia, eclampsia. And hypertensive diseases of pregnancy are relevant because we know that that predisposes the patient to heart disease as they get older. So this is sort of building the case that this population is truly a high-risk population. What happens in terms of pregnancy and pregnancy outcomes? So this is a study that showed, it's part of the PCOS2 study, where we showed that in the blue line are the patients who had metabolic syndrome. Their chance of getting pregnant is much lower than a woman who does not have metabolic syndrome. So even in terms of counseling as to what is your chance of getting pregnant, this becomes a relevant marker. And then of course, it's no surprise that they have a higher risk of gestational diabetes, macrosomia during pregnancy. So I've shown you evidence for metabolic syndrome and metabolic disease in PCOS affecting reproduction. There's another important component of PCOS we shouldn't forget, and that's the psychological health of the woman. And why is this important? It's important because women with PCOS have a high risk of depression as well as anxiety, so much so that we included it within the guidelines and said that we should be screening all these patients, at least when you make the diagnosis one time, maybe over time as well, for anxiety and depression. Why does it become relevant in a talk for cardiovascular disease? Because we know that patients with depression have a higher risk of cardiovascular disease in the general population. And then this is our study where we have this cohort that I mentioned at Penn. When we followed them through about a 10-year period, you can see the lower line is the patients who have no depression or anxiety. And then the top line is the one with depression and anxiety. And so the presence of depression increases the risk of metabolic syndrome in this population, and it's not driven so much by anxiety. So there's an interplay between reproduction and cardiometabolic health, between psychological health and cardiometabolic health in this population. So in summary for this part, I think we have good evidence now that we can counsel our patients high risk of obesity, diabetes, metabolic syndrome, dyslipidemia, anxiety, depression. High risk not when they're 40, 50, 60, but in their 20s and 30s, unfortunately. High risk if the androgens are elevated, there's hirsutism, so within that phenotype. And we are seeing it worldwide. This is not unique to a certain population. So having showed you that evidence, so moving on to the next stage then, do they really, when they are 40, 50, or 60, have a higher risk of cardiovascular events? You know, that's, I think, the main question that we've had for several years now. And so let's look at some of that evidence. So the first level of evidence comes from subclinical atherosclerosis. So you can test for the carotid intima media thickness and look at that. One can test for endothelial function and look at flow-mediated dilatation. And the reason we have done a number of these tests are because we're not going to see the heart attacks or the stroke at 20 or at 30. It's too early, and the prevalence is going to be low. So the way one would pick up disease is by looking at some of these markers. And this is a meta-analysis that shows over 73 studies with CIMT, and you can see that they've significantly thickened carotid arteries. And similarly, when they looked at flow-mediated dilatation, there's impairment of flow. So again, this builds evidence that in these young patients, we're starting to see some evidence of subclinical atherosclerosis. My group and others have also looked at coronary artery calcium scores in these patients. And there are few studies, so only about 6 studies have been published so far. And most of them are showing an increase in calcium deposition around the perimenopause. So a little later, but again, this is pointing towards not just that there is plaque formation, but calcification and hence advanced disease in this population. So having established that PCOS is a cardiovascular disease risk-enhancing factor, what is the data that we now have that's supporting actual events in this population? And I'll walk through some of the data, which I'm sure by the end you will be convinced that this group is indeed at a higher risk. So this is one large Apple women's study that's been conducted in the US. So through the Apple Watches, women through surveys have been entering their data. At the Harvard Medical School, they have a collaboration. And so what you see in this fairly large 52,000 women with PCOS, they have the increased risk, as we know, high risk of diabetes, cholesterol, hypertension, metabolic syndrome. And then the lower bracket shows you the higher risk of coronary artery disease, heart attack, and stroke. Survey data, so it's not confirmed. So let's move on to studies that have looked at patients that are hospitalized. So here is a study early on from Australia that showed us in the hospitalized female patient population, when they looked at PCOS and non-PCOS, they found that the PCOS patients had a higher prevalence of circulatory or cardiovascular events. And then this is the data from the US, a slightly bigger group, 13,000 patients. Not all of them older, even though it went from 15 to 65, but again, higher risk of cardiovascular disease, MI, stroke. You might say these are hospitalized patients, so this is the more severe case of PCOS. So, you know, on one hand, we had the surveys, then we had the more severe phenotype. What about in the outpatient setting? What are we counseling this patient population? So this is a fairly large study that's come from the UK. It's from Alid Rees's group, and they have a larger population. It's the NHS, so they have good electronic records for all of their outpatient visits as well. 174,000 women. And so as you can see in each of these graphs, they're looking at the composite outcome, MI, stroke, and for each of them, almost excepting mortality, the survival in the PCOS patient is significantly lower than the non-PCOS patient. And then the most recent study, which was published, which was it was presented in Madrid just 2 weeks ago at the World Cardiology meeting. So this has come from Denmark, 25,000 women with PCOS. And then that top line in red is MI, myocardial infarction, and stroke. And the combined line cumulatively over years again shows an increased risk. So I think we now have significant evidence here, unfortunate that this young population is not only at a risk for cardiovascular risk factors, but ultimately results in cardiovascular events. And then we talked about hyperandrogenism being a significant part in this. Interestingly, in this smaller study that came from Finland, and the reason I show it is because they have a very good 22-year follow-up. They are showing no difference between the NIH or the Rotterdam definition. And one would have thought that maybe the NIH criteria, which include the hyperandrogenism for sure, would have put them at a higher risk. So I think more to be done in terms of phenotypes and these outcome differences. But I just wanted to put that out to share with you. And then this is our study from the US. This will be the largest study when it's published. The paper is under review now. So these are 420,000 women with PCOS. And again, when we adjust for just about every variable, so including what others have already adjusted for diabetes, smoking, hypertension, we were able to include obstructive sleep apnea, fatty liver or MAS LD, depression, anxiety, use of medications, and including all of those risk factors, it's still a 4-fold increased risk of ASCVD, and then for all of the components, coronary artery disease, cerebrovascular disease, peripheral vascular disease as well. And then when we look over time, so at the youngest age, when in the first year of diagnosis, you can see the red line is the PCOS group. This is the cumulative risk of ASCVD. And as we follow these patients, that risk keeps broadening and increasing. And as they're older, towards the perimenopause and beyond, significantly higher risk than the control population. And again, the question is it because they have hypertension, because they have diabetes? So we did what's called a mediation analysis. So that gives you a sense of how much are these traditional cardiovascular risk factors contributing. And as you can see, the bottom number is only 36%. So there is another independent PCOS factor, be it hyperandrogenism and other inflammatory factors that might be explaining this additional risk. And then I put in this data, which is again, as part of that study, unpublished right now, when we looked at the racial differences for each of these, and the black race seems to have the lowest survival, followed by the Hispanic race that we have in the US. The Asian seems to be the least affected. However, I wanted to point out that in the US, the way the demographics work is everybody's put in the Asian bracket. So the Southeast Asians, Indians, and I think this will separate out. When you look specifically at an Indian population, they are always at a much higher risk when you eliminate the rest of the Asian group. So in summary, in the international PCOS guidelines, when we updated them last year, we added that PCOS should be considered as a risk factor for cardiovascular disease, and we should be screening these patients. We were always screening them for an oral glucose tolerance test because we knew about the risk of diabetes. We were not doing a good job about adding the lipids in it. So I think that's the main change that's going to occur in terms of the screening guidelines. And so finally, the last part of the talk is to sort of try to understand why are these young women at this high risk, and what can we do in terms of screening them early. So when we look at the genetics of PCOS, there are a number of GWAS studies that have been published now, and this is a Manhattan plot that's showing you the candidate genes. There are about 20 candidate genes that are associated with PCOS. And below that, what I'm showing you is an LD regression analysis. When you look at cardiovascular risk factors and the PCOS genes, there is significant association. Again, telling us that genetically, these patients are predisposed to cardiovascular disease. And then when one does the non-hierarchical cluster analyses looking at these candidate genes, there are really two clusters within the genetics. One is the metabolic cluster, you can see in red. So high BMI, high insulin. They have the lower LH, SHBG. And now the low HDL and blood pressure phenotype is also tracking within this metabolic group. And then there's a separate reproductive group, which is the high LH, the traditional diagnosis of PCOS. They have the lower BMI, so what we used to think of lean PCOS, high AMH, which is anti-Mullerian hormones, and high AFC. So as we counsel our patients, they're not all the same. The PCOS is very heterogeneous, but through the genetics as well, one can identify, and hopefully these biomarkers will be available over time, that you could say you're the metabolic profile and you may be higher risk for PCOS, and you're a reproductive profile and maybe a lower risk. So that's one component, is to understanding the basis for cardiovascular risk. The other one, which we've recognized for a while, is that this is a state of low-grade chronic inflammation. And that's arising from that visceral adiposity and the fatty sort of tissue dysfunction. So my group, we've been primarily interested in the dyslipidemia, which comes from adipose dysfunction. And when you do a lipid profile or a cholesterol profile in PCOS patients, the LDL is not always elevated. HDL also is not always low. The most common is a high triglyceride. So we asked the question, is that HDL functional? And there's an assay, which is the cholesterol efflux assay, and when you look at that, the HDL doesn't work as well in the PCOS population. The efflux capacity is lower. Or if you look at the LDL particles and you do an MR spectroscopy and look at actually VLDL and LDL particle size and number, it's more atherogenic. So early on, they're starting to show some of these parameters. We don't see it in a usual lipid profile, but if one was to do a more deeper lipid phenotyping, it's already evident in a younger age. And then when we talk about obesity in patients with PCOS, it's more central. It's not the peripheral obesity. And again, when you look at the GWAS and the genetics, in the lean patient, the genes are tracking separate than what one sees in the obese patient. Again, indicating a little bit of a genetic background and predisposition to these different phenotypes that we see for PCOS. And then the final thing in terms of pathophysiology that's sort of newer on the horizon is that we've always understood that PCOS is associated with high testosterone, total free testosterone. Those are the classic androgens. What we now know is that the 11 oxyandrogens are also elevated in PCOS. So the enzyme AKR1C3 converts the precursors, which are the androstenedione precursors, into both classic testosterones as well as 11 oxyandrogens. And these are believed to be even more potent attaching to the receptor. So if you look at this last figure here in the red, in the adipose tissue of PCOS patients, AKR1C3 as an enzyme is elevated. And so that might be driving higher levels of 11-oxytestosterone. And so we might be increasing our panel and not just measuring. So we typically measure testosterone DHEAS, and this might be another part of that entire androgen family that we might be measuring in the future to get a better assessment of the phenotype of our patients. Just very briefly, the in vitro experiments for AKR1C3 show us that insulin drives the levels of AKR1C3. So again, tying in the insulin resistance in PCOS with hyperandrogenism. And the pathway is the same. So it's the same pathway through PI3 kinase, AKT, as well as mTOR. And then the nuclear receptors are similar. So insulin seems to be the driver for AKR1C3 in adipose tissue. And so again, in summary, if I had to put all of this in a slide, you have the ovary and the adrenals giving us the precursors, AKR1C3 in fatty tissues, which is what's prevalent in PCOS, converting it into classic androgens, 11-oxyandrogens. They bind to the androgen receptor in the fatty tissue, and then they activate fatty acid synthase. Similarly, insulin can drive this whole pathway, and then when fatty acid synthase goes up, we get the dyslipidemia. And then the dyslipidemia again drives metabolic syndrome. So I think, in trying to understand what's happening in this young population and what is the target, where can we break this cycle? We've been treating the high androgens with birth control pills. We've been treating the cardiometabolic risk with metformin. But if we go upstream, and we block AKR1C3, might we be in a better position to offer our patients more sort of comprehensive management? So there are a couple of these newer drugs that are in the pipeline, so nothing available yet, but I think this is an area that is being explored for future pharmacotherapy in PCOS. And then I'm going to end with just sharing with you, we have 2 studies that are coming out looking at the effect of our first-line medications, because one has to ask the question, if our patients are at a high risk for cardiovascular disease, are birth control pills, is metformin the right therapy as first-line therapies? We've always looked at short-term outcomes. So when we look at metabolic syndrome, which was the sort of surrogate marker our group has used with respect to insulin resistance, dyslipidemia, really birth control pills are not harmful, and metformin doesn't make that much of a difference in a short term, like over a 6-month period. And this data will be published hopefully in the next couple of months. So now the study that we are doing is, what do birth control pills and metformin do long-term to cardiovascular disease risk? And again, not published, but I can tell you that both of them actually are protective, and the risk of the heart disease, both MI and stroke, is lower in the population that's been exposed to birth control pills or metformin compared to the ones that haven't. So maybe good news for our patients that we can continue with our current first-line therapies, but both of these are still unpublished. So let me end with sort of that cardiometabolic assessment, which again is what this population, and these group of physicians, and you guys are all doing typically, is the weight management, glucose screening and management, blood pressure. We've added in the lipid screening, and I don't have time to show, but there's a lot of data talking about obstructive sleep apnea in this population, as well as MAS LD, and of course depression that we talked about. I put this slide because on the link at the top are very nice brochures for patients. They have been prepared as part of the international guidelines. They're free to download, very soothing to the eye and pleasing, and we've taken patient input. So please, if any of you have a focus in the PCOS area, take advantage of this, share it with your patients. All of these are free resources. And I would like to thank my entire team at Penn PCOS Center, as well as collaborators internationally, for my PCOS journey. And I'm going to leave you with an invitation. There's a society just dedicated specifically to PCOS. Our annual meeting this year is in San Antonio, and it's an amazing 3 days of clinical, translational, basic science, and very multidisciplinary, because as you can tell, these patients really cannot be managed by just one group of physicians. So please do come along, if not this year, any of the following years. So thank you so much.
So, thank you very much. It was a really excellent and elaborated presentation on PCOS and cardiometabolic risk. And generally, we understand that cardiometabolic risk, cardiovascular risk in PCOS is mainly because of metabolic parameter and obesity. But you rightly said that androgen axis is the driving force, and maybe that whatever androgen axis we are treating with OCP, that may be beneficial. Though it is not proven now, but it may be beneficial in future. So I have one query, that we, along with OC pills for androgen axis, we give androgen receptor blocker. So will they make any difference, because they are not only androgen receptor blocker, but they also antagonize aldosterone, and aldosterone renin axis is also elevated in PCOS. So this spironolactone also generally we give.
You can hear me? Yeah, I think that's a very good question as to the dual combination, because as you know, the birth control pills will suppress LH and suppress the ovarian androgen production.
Yes, ma'am.
And then in terms of what's happening at the periphery, will it be able to block it enough? And typically when we use spironolactone, we see an impact in terms of acne being better, hair growth a little better. But if you don't give the birth control pill, the serum androgens don't drop because it's peripheral.
Yes, yes,
So it's always second line. It wouldn't be first line.
correct.
Yeah, and the bigger effect is going to come by suppressing the hypothalamic pituitary axis. And I think time will tell. We don't have the studies if spironolactone will be as important.
Because they are aldosterone antagonist also.
Right, so because of a secondary action, will it
Yes,
have
ma'am.
some benefit will be a good question
Yes.
to ask in these studies,
Yes,
yeah,
ma'am.
yeah. So in our second study, which the last slide I showed, we will get that data for who is on spironolactone as well, yeah,
Yes,
yeah.
thank you. Any question from audience?
That was a wonderful talk, Dr. Anuja. Very, very well elaborated. I'm Dr. Lakshmi from Hyderabad. I'm an endocrinologist. We see a high rate of PCOS in young women these days, very young girls. And I'm also seeing most of them are overweight, but also 25 to 30% of them are very lean. So there is hyperinsulinemia. There is obviously a family history of diabetes-related complications. And the girls are lean here in this category. So my question always clinically is, should I give them metformin and what dose, a full dose of metformin? And another doubt is like when patients have regular menses, but they have hyperandrogenism, cosmetic appearances, which they are not happy about. So in that case, should we still give them OC pills along with an anti-androgen, like how Dr. Modi was mentioning, and a combination of metformin even in the lean PCOS girls? Is something always, there's a clinical debate in my head. What do the data say? What do the experts say? And what do my colleagues do usually are my doubts.
No, and these are all very good and important questions. I think, 30 years ago, we all understood there was a lean PCOS phenotype and an obese. And then with the epidemic of obesity all over the world, most of our patients became sort of the overweight, obese PCOS. And there's very few lean, even in India now, so many more are overweight or obese. But I think even the genetics are showing us that there is a lean phenotype, which is a little different. The lean phenotype may be more the reproductive phenotype that's showing up. So high LH, if you do an ultrasound, the ovaries have more of that AMH or the AFC being high. They may not be at metabolic risk, but we don't know that yet. So I think if you get the high androgens, one has to address it, because if the patient is coming with hirsutism acne, you want to manage that. I'm not sure what the role of metformin is then, right? Because if they're not the cardiometabolic phenotype and you're only managing high androgens, you could just do a single agent treatment. It's very hard. We prescribe so many medications for these young girls. That's hard, and then they stop everything. So in some ways, if we just target what their problem is, at least they may continue with the one medication, start giving them OCP, spironolactone, and metformin, and they stop everything because it's too much. That doesn't help us either. So I think we have to be a little cautious about polytherapy. And then we keep telling them lose weight. So then they go into this whole spiral of being on a diet, not being on a diet. And that's where the psychological health comes in as well. So I think you're asking the right questions. What do we do and how do we manage? And I always feel the first thing is we want to treat our patient. What is their problem? If something bothers them most, treat that first. And then as the confidence builds and you can track it, if the weight doesn't change and the lean person doesn't have that visceral adiposity, maybe you can wait to do because metformin is preventive, right? You're not treating anything in this young patient, yeah. So I think it'll be personalized medicine is what happens at that point, yeah. The guidelines are not this specific, yeah.
We are using a lot of cyproterone acetate, an anti-androgen drug for patients who have severe hirsutism or severe hyperandrogenemia. Do you have any experience, or will it also help in reducing the atherosclerotic cardiovascular disease?
Yeah, so cyproterone acetate is not available in the US. It's available in Europe and here. And then I thought because of the risk of meningiomas, didn't it go out of It was, at least in Europe, they stopped Diane and Diane 35 because there was some evidence. But there are a number of studies that show it's a good choice. Not alone, I think with the ethinyl estradiol, because that will suppress your axis better. But it's been shown to be a good choice for a number of sort of studies that regulate menses, drop androgens. Any pill that will drop androgens, the lowest dose is sort of what we are recommending in the guidelines. You don't have to do the 35 or the 30. Even a 20 microgram will drop the androgens significantly into a normal range. So okay to use the lowest dose. And we don't know for sure that one progestin is better than the other. The 4th generation progestins are now available, the drosperinons, and those seem to be well tolerated. There's a new pill that's only drosperinone, 4 milligrams, that adequately suppresses the axis as well. So if we think it's androgen-driven cardiovascular risk, all of these will suppress it. There's of course a component of traditional risk factors, hypertension, diabetes, you have to manage that as well. So it has to be a combined treatment, but the birth control pill has a very small risk of hypertension, and that's really our only problem. The weight gain is not as much of a problem with birth control pills at the 20, 25 microgram dose anymore. And if you combine it with the water pill, then the bloating isn't so bad. So I think we are coming away from thinking OCPs are bad to, again, they're beneficial for this PCOS group.
So if there are no questions, we'll close the session. And thank you very much, madam. It was really enlightening, and we learned a lot. Thank you very much.
Thank you.
Thank you, ma'am. Thank you, ma'am, for the excellent session. As you all know, PCOS is highly prevalent in Indian population, and I'm sure this session has been truly impactful and insightful for all of us present here. Now for the next session, that is on Turner syndrome uncovered from genetic basis to care in adulthood. I'd like to invite our next chairpersons on the dais, Dr. Jamal Ahmed sir and Dr. Pathophysiology Chaudhuri sir.
Good morning, everybody. Thank you so much, and I'm grateful to the entire team of the organizing committee for calling us here. We are going to have some thought on the Turner syndrome from the basic to medical care. You know that Turner syndrome is the commonest sex chromosome disorder, and the prevalence is something like 1 out of 2,000 or 2,050 born girls. We don't know exactly what is the cause of Turner syndrome. The 95% girls with Turner syndrome have the classical manifestation of Turner syndrome, what we read in the textbook, that right start from the short stature to primary amenorrhea to delayed puberty, a series of skeletal abnormality, some congenital cardiovascular, renal, skeletal manifestation. That is what you call the classical syndrome. And karyotypically, we say that is 45S. Then we say a lot of mosaic cases of Turner syndrome. who have karyotypically, they have got 45 S, but they do not have the classical manifestation of Turner syndrome. They may present with primary amenorrhea, gonadal dysfunction, and some of the other manifestations, but the classical manifestation is not there. The third type of case that we commonly uncommonly, I'll say the uncommonly see, is tall Turner syndrome. Not many cases of tall Turner syndrome have been reported in the literature. I think, to my mind, not more than 25 cases of tall Turner syndrome has reported in the literature. I also reported one case of Turner syndrome, I think about 20 years back. And there was another report from the Korean population in 2015. They also reported a case of tall Turner syndrome. The classical manifestation of tall Turner syndrome is that they do not have any classical manifestation of Turner syndrome. They are, in fact, they're tall. The girl that I reported was almost 6 feet height, and she presented with primary amenorrhea, hypogonadotropic hypogonadism, and infertility. Again, the exact etiology of tall Turner syndrome has not been clear, but this is said that it is because of the overexpression of SHOX gene that might be responsible for giving rise to tall Turner syndrome. There have been some advances in the diagnosis, right from the prenatal diagnosis, whether you do the karyotype, the villus analysis, or if you suspect the prenatal diagnosis of Turner syndrome. And the available techniques which are commonly used are the classical karyotype analysis, then we have got G-banded chromosome analysis, and we have got microarray, and then we have got SNAP type of techniques that are used for diagnosis. The Turner syndrome is not a genetic disorder, it's a sporadic disorder, and we exactly don't know what exactly the cause. The environmental factors, do they play any role, is not very clear. Advancing maternal age has not been reported to be responsible for giving rise to manifestation of Turner syndrome. So we have to learn and let us see that whether we have got any further advancement in the diagnosis of Turner syndrome. As for the management of Turner syndrome, I will just mention about 10 seconds. Classically, the teaching is that give growth hormone therapy at an appropriate time, continue till the girl is 14 years of age, bone age, and if still she is growing, you can prolong the treatment of Turner syndrome by growth hormone therapy. Then we try to give estrogen because they are estrogen deficient girls. Some other additional factors, whether they play any role, is not very clear. When you used to be a student in 85, Dr. Jindal is sitting here. We also used to give exenderon that is not commonly used, and it has been now banned in some of the country. So with this short memory, I will just invite Dr. S.D. Gupta. He is additional professor in the Department of Endocrinology and Metabology at AIIMS in New Delhi. His basic research interest is GDM, diabetes and pregnancy. He had more than 200 publications. Has been awarded RSI Novartis Young Investigator Award, Anil R. Sheth Young Investigator Award in 2020 in the field of clinical endocrinology given by Endocrine Society. He also got AIIMS Excellence Research Award 2010 for clinical category. Dr. S.D. Gupta, please.
Thank you, sir. My regards to you, and thanks for the nice introduction. And my sincere thanks to ICON 2025 Organizing Committee for this invitation and made me here to speak on this topic. So this is a garden variety of a case which we usually see in our clinics, like a female which is presenting late and probably first time to the endocrinologist with a delayed puberty and short stature. And there could be some additional history like ear discharge, issue with hearing, or some vision related issues. And when you examine, you find some stigmata suggestive of Turner syndrome. And on further investigation, your doubt is confirmed that patient is having hypogonadotropic hypogonadism, and karyotyping is suggesting of a classical Turner syndrome. And then there could be further concerns for fertility. And this patient has never been evaluated in detail. So basically, my broad aim is to stress upon the clinical points, and in each of the area, just elaborate 2 or 3 main points which we need to keep in mind while dealing with such patients. So there are certain stages where you can diagnose. If your suspicion is quite high and on routine investigation in the antenatal period, you may detect some patients suspected to be Turner, but not all if it is a systematic screening. And if there are no classical stigmata like cystic hygroma, lymphadenoma, or classical facial phenotypes or other classical stigmata of Turner at birth, or left-sided obstructive heart changes, so you may miss till adult age when they have concerns with the short stature or delayed puberty. And if that are not the case, then you may miss even late and may not diagnose even in the late 50s or 60s. So what has been seen that in the global literature also that 15 years is a median age of diagnosis for the Turner syndrome. And even at AIMS data of compilation of 54 patients published in couple of studies, the mean age of presentation was 15.7. So it is not different as compared to the Western data. So a similar sort of presentation we do see in Indian is been reported in the outside area. So why we are discussing this and the clinical aspects of Turner syndrome? Because of the high morbidity and mortality, and we need to learn where we fall in our clinical management pathway that leads to this high morbidity and mortality. So it has been seen that the apparent lifespan of Turner syndrome is 13 to 15 years less compared to the general population. And cardiovascular diseases are responsible for 50% of the mortalities, and other factors that are contributing are digestive, genitourinary, respiratory, and broad area of all organ system has some contribution in the morbidity and mortality. And endocrine diseases are also responsible for increased hospitalization and morbidity, though not directly to the mortality part. So let me take you by issue by issue. So first, prime concern at this age for a young female will be pubertal related issues, and subsequently regarding to fertility. So how common is the pubertal failure? So it has been seen that signs of puberty means thelarche that could be seen in 30% of the patient, but spontaneous menarche is only seen in 20% of the women. So 80% will not progress through the normal puberty, and this figure can be as high as 90%. And spontaneous pregnancy will be seen only in 10%. Obviously, there is a variation, as sir said, that 45x0 is basically a classical phenotype and is responsible for most of the defects that we see. And if it's a mosaic phenotype, you may see some of the patients, means a higher number of percentage of patients having a spontaneous menarche for pregnancy, but even that figures are not too high. So when you talk about regarding the pubertal induction, there will be certain issues like what is an adequate timing, what will be the adequate formulation, what will be the escalation plan, what will be the duration of induction, how we maintain it, and how long we have to give. So these are certain clinical questions that will come in mind when you have to plan an induction for pubertal induction for such patients. So there is a universal agreement on timing of pubertal induction of 11 to 12 years. It could be a later if there is a growth concern, otherwise it can be started at 11 years. There are a couple of studies which have even induced late at 15 years, or means for pubertal induction, but net gain or loss benefit risk ratio suggests that 11 to 12 years is an ideal time for starting induction. So how you decide? If FSH is elevated on at least 2 sequential measurements, either you're doing annual measurements if the patient is presenting early. If the patient is presenting late, you may have to do 2 consecutive measurements 4 to 6 weeks apart to confirm the biochemical persistence of abnormalities. And if you can couple it with the clinical phenotype, means failure of the LARC or failure of progression of normal puberty, then you're more confident the patient is not having any pubertal onset or is having arrested pubertal development. So you have to initiate with a low dose estrogen. Low dose estrogen, if we are starting at 11, we may see, maybe see in the next slide, and then slowly increase to adult replacement doses over 2 to 4 years. So if you're starting early, for example, at 11 years, then you have to follow the 4-year plans. If you're starting late, you may can decrease the pubertal induction duration. So if the patient has presented early, so if it is a 4-year induction plan starting at 11 years, then you have to start only with the 1/8 of the total dose for 1 year, then 1/4 of the total dose of adult dose for the next year, then 50% of the maximum dose for the 3rd year, and full dose for the last 4th year. So how you monitor? And the formulations are basically transdermal dose, which is recommended as a first line therapy, but due to cost issues and due to the availability issues, we usually prefer more of the estradiol valurate, but wherever it is available and can be used and patient is comfortable, transdermal 17-based estradiol patches are recommended as a first line therapy. So there are ways to titrate. Either you're doing a biochemical monitoring, but more ideal way is to target the clinical endpoints, which is a breast stage development. Like at the end of each induction dose, you should have progression of 1 stage for the breast. And there are some parameters for the uterine development also, which can be taken into account when you titrate or assess the adequacy of estrogen supplementation. Serum estradiol has been recommended, but only for the transdermal patches. It is not an ideal way of monitoring for the oral estrogen. And if you are using this estradiol values for titration, so then you have to do 2 days after a patch application, and there are recommended levels for each stage of titration. For such a girl which is presenting late, 18-year-old female, so you can have a shorter escalation period, which could be 2 years, in which you give 25% of the dose in the initial 6 months, 50% of the total dose in the next 6 months, and then can go to the means full dose in the 3rd year. Usually in the 3rd year, we use 75% of the total dose in the means 12 to 18 months window, and then 18 months onwards we do the full dose. But these are the recommendations which are there in the current clinical practice guidelines of 2024. What are the pros and cons of each formulation? Transdermal estradiol is a reference, the best one, which mimics estrogen physiology, avoids first pass liver metabolism, has a better cardiovascular and metabolic outcomes. Oral estradiol valurate is a second choice. Is effective, but a little bit less physiological, but there are no significant concerns for the oral estradiol, and this is what we use at AIIMS in almost all of the patients. There are concerns with the conjugated equine estrogens, which is no longer preferred. One should totally avoid conjugated equine estrogen. Ethinyl estradiol in a young patient is not physiological because there are some diurnal variation on estradiol levels in the initial stages of puberty. Ethinyl estradiol is not able to mimic. So there could be a supraphysiological exposure. So initial stages of pubertal reduction, one should avoid ethinyl estradiol. But once patient is on full dose of estradiol and progesterone is added as a combination pill, then ethinyl estradiol can be given due to the convenience perspective. There are no major side effect profile, but obviously, as I said, that ethinyl estradiol is a supraphysiological for a young female. You may see some increment rise in systolic blood pressure and diastolic blood pressure. So monitoring is required when ethinyl estradiol is used as a part of induction or even later on. And there is no major concern for the liver toxicity. Even it has been shown that it is beneficial if there is some enzyme elevation,
So it should not be delayed or modified. The dose can continue even in the presence of liver abnormalities. And one should try to avoid oral conjugated equine estrogens due to some concerns, though it may not be too visible in the Turner syndrome or not too much commonly reported in the Turner syndrome. Overall, there is a benefit of HRT, and especially I want to mention in the slides regarding the liver enzymes, because obviously we see that sometimes there are liver abnormalities which could be a part of Turner syndrome. And oral estradiol or this 17-beta estradiol formulations are actually beneficial in such cases rather than causing harm. Given that if there is a strong suspicion, if more than 2 times elevation of liver enzymes is seen and there is some suspicion of nodular hyperplasia, then one may have concern. Otherwise, plain abnormalities of liver function is not a concern for the estradiol replacement. So the next question will come: when to add progesterone, formulation and dose. If you are using a shorter version in the adult female, then it is a 18 months time. If you are using a 4 years longer version of early pubertal induction, then it will be 36 months of unopposed estrogen. That is one parameter. Second is obviously a vaginal bleeding, but if you see early vaginal bleeding earlier than 18 months or earlier than 36 months, given whatever the pubertal induction duration you are using, then you have to get an ultrasound to rule out some local causes. If there is no bleeding after giving unopposed estrogen for an adequate time of period, then you can do a uterus imaging and see if it is mature and endometrial thickness is more than 4 mm, then again one can start progesterone, and ideally breast age late 4 and early 5 is an ideal period for starting progesterone. So there are a number of parameters that should be taken into account rather than 1 or 2 parameters. So micronized progesterone is preferable, but given the cost and availability, medroxyprogesterone could be a replacement. 10 to 14 days is recommended. We use a 10-day regimen of day 12 to 21, and 5 milligram of medroxyprogesterone can be added for the completion of the hormonal replacement therapy. So how long? Usual age of menopause in the Western settings is 50 to 5 years. So you will see these figures in the Western literature. In Indian settings, it's around 45 years of menopause. So one can decide what could be the period of duration, but 35 to 40 years is a usual recommendation of replacement for gaining the adequate impact. Fertility will be issue. 10% is a spontaneous conception. It could be 2 or 3% in the classical phenotype. If it is a post-pubertal, then oocyte preservation is recommended after ovulation induction. If it is a pre-pubertal, then ovarian tissue cryopreservation is recommended, given that there is an adequate reserve for that both parameters. And if patient is having spontaneous menarche and is having ovulation, spontaneous ovulation, but is not able to conceive, ART is recommended. Otherwise, there are adoption or foster care or other alternatives which are available. What is important that though there are recommended fertility preservations, issues like oocyte vitrification or ovarian tissue cryopreservation, but only so far 1 pregnancy each has been reported by both of the methods. So we do not actually know what will be the translational value of preservation, and that should be kept into mind when offering such options to the patient. The second case, second issue is a hypertension and cardiovascular issues. In hypertension, BP should be monitored at each and every visit. What is important is whether aortic disease is present or not. If it is present, then beta blocker should be a part of a regimen. If it is not present, then standard antihypertensive drugs can be used. And if there is a hypertension, renal anomalies, coarctation of aorta, obstructive sleep apnea, and obstructive uropathy that need to be ruled out. Prevalence is quite high, 40 to 60%, so you need to be vigilant at each and every stage. Congenital heart disease, as I said, it may manifest in the antenatal or the early neonatal period, but if it is missed, then it has to be evaluated in detail later on. The prevalence overall is around 50%, and bicuspid aortic valve, coarctation of aorta, aortopathy, these are common congenital anomalies that can be seen. Cardiovascular disease per se is not common, but there is a high propensity of having cardiometabolic risk factors, and these need to be kept under check to avoid future complications like ischemic heart disease, cerebrovascular disease, and also to take care of the congenital heart diseases to avoid further complication like aortic dissection or atrial fibrillation, because we know that it is responsible for 50% of the deaths. The prevalence of bicuspid aortic valve is around 25%, and it is a marker that if it is present, it could be having a coarctation of aorta or further aortic dilatation or dissection. So that again is a very good marker for follow-up of the patient. It is not only that these 3 abnormalities are present as a part of congenital heart diseases. There are a number of other anomalies that are seen and which can't be picked up on the classical echos or other clinical parameters. So MRI is the most sensitive or the specific modality that should be offered to the patient of Turner syndrome for diagnosis purpose. And the other modalities that exist is a thoracic echocardiography and the CT as alternative to MRI if patient is not able to get it done. Each modality has its own role at each stage because MRI may not be feasible in the young children. So transthoracic echocardiography plays an important role in the initial 10 years, but once the patient is able to cooperate for the MRI, that becomes an investigation of choice. And in pregnancy also you can't do MRI repeatedly, and some patients require every trimester evaluation for anomalies or the progression of dissection or aortic diameter. Then transthoracic echocardiography also again plays a role during pregnancy. So what is important to know from a clinical perspective? Obviously cardiologist has a main role to decide when to intervene and how to intervene, but what you need to know as a primary care physician, that if everything is normal, the follow-up imaging can be after 5 to 10 years, but if there is any suspicion, the imaging can be shortened to as early as 6 to 12 months. So basically we have to ensure that patient is having a proper cardiology referral and cardiologists understand what are the specific issues related to the Turner syndrome and how to deal, and we just have to ensure that is taken care of. In pregnancy, the recommendation is to use and assess patient within 2 years of pregnancy and once as close as to planning of the pregnancy, and you need a very close follow-up each trimester to look for the progression of any adverse issues like aortic dilation or aortic dissection, and patient should be referred and measured in the higher centers. And the one thing which we can do is a adequate BP control of less than 130 to 80 to avoid any further complications during pregnancy. Regarding cardiometabolic risk factor screening, how these patients differ from the rest of the population, usually we have understanding that adult patients should have routine screening at 30 years of age, and if there are risk factors, maybe early. In case of Turner syndrome, weight and BP, these are non-invasive. So that has to be offered at each visit. The invasive cardiometabolic risk factor profile like A1C, fasting, that has to be offered at starting from 10 years, and lipid profile at 18 years, and then subsequently annually to 3 annually, depending upon what parameter we are testing, should be continued as a part of cardiometabolic risk factor assessment. Exercise, again, one should be clear. When you prescribe or recommend any exercise or patient specifically ask for some exercise schedule, but you have to take care there is no major aortic related issues. If there is no aorta related issues, normal exercise plan can be advised, but if there is a mild to severe spectrum, one has to restrict activities which can put patient at risk. So the third issues could be ear discharge. This is again one common comorbidity seen in the patient with Turner syndrome. So mainly the eye-related problems are congenital, comprising of strabismus, refractive errors, congenital and acquired glaucomas, cataracts, and these need a comprehensive evaluation as close as to birth to rule it out, because it can lead to permanent loss of vision also. But in case patient has missed early assessment, one has to get a proper detailed assessment of ophthalmological issues at time of presentation, and after that only when patient reports some issues related to vision and eye related issues. Ear, again, one has to be very vigilant because hearing loss is quite common in this patient. Both conductive and sensory neural hearing loss is seen, impacting 30 to 80% of the patient. So middle ear disease, including effusion cholesteatoma, that are common in the young age, and even yearly evaluation has been recommended in the children, including tympanometry. And even in adults, every 3 to 5 years, because sensory neural hearing loss is also quite common, so it is better to get an audiogram. But in case patient is perfectly normal, not complaining of any issues, then it can be on the elective basis also. Short stature, this female particularly is 18 female completed and beyond a point where we can do anything. But in general, the recommendation is to start growth hormone at 4 to 6 years, at least give for next 7 to 8 years. So there was a Turner totaler study which suggested that it can be started close to 2 years, but ultimately follow-up of that particular study has shown that there was no difference in outcome, even the patient who started late. So the toddler group also suggested that the growth hormone can be offered at 6 years. The main aim is to continue and maintain the therapy. So if it is 8 years of growth hormone therapy, one can achieve a height of 5 to 8 centimeter, which can vary and can be higher in certain subgroup of patients. The only point what we need to keep in mind during growth hormone therapy, that when you're doing pubertal induction, low dose estradiol has to be used till you're using growth hormones. So even if you're starting at 11 years, it is better to expose patient to not more than 25% of the dose of ethinyl estradiol during growth hormone therapy, because that is a having stimulatory effect. Higher dose having a prohibitive effect can result in early epiphyseal closure. So one should allow patient to have adequate height gain, and then should supplement patient with the higher doses of ethinyl estradiol. Due to time paucity, I could not cover some other issues, gastrointestinal and hepatic issues. Celiac is important. Then there are some other phenotypic characteristics which need detailed evaluation. Neurocognitive part, psychosocial is also very, very important and need a proper assessment by the psychologist. And the other part which Sir was elaborating, that different karyotypes and association with different phenotypes. So this is one thing which is still in the stage of understanding. No clinical guideline is based on different aspects of karyotypes. So one has to follow a universal path of management for each and every patient irrespective of karyotype till the time we have a detailed understanding. So there are a couple of papers from AIMS also, and we also did not find substantial difference on the basis of phenotypes or other parameters. So the take home message is that pubertal induction has to be started at 11 to 12 years. Predominantly there will be a loss of bone if we start late. 17 beta estradiol is a good formulation. Oral, transdermal, whatever is available. Breast, uterine, BMD, personal satisfaction, there are key parameters for up titration. Hypertension is common. One should be aware of the congenital heart diseases and evolving cardiovascular diseases. And control of cardiometabolic risk factors can substantially elevate the cardiovascular mortality in such patient, and one should be vigilant close to pregnancy. Spontaneous pregnancy rates are only around 10%. Oocyte preservation and ovarian tissue cryopreservations are modalities available, but we hardly had any pregnancy outcome on such patients. Ear abnormalities, celiac disease should be part of ongoing comorbidity assessment, as is the skin evaluation, which also requires annual assessment. And there are a number of other organ systems which are affected and needs periodic screening and attention of clinician for optimal outcomes of such patient. So thank you so much for your kind attention.
Thank you, sir, for your wonderful discussion. And I would like to request sir to come here and join us here. For the next topic, genetics of Turner syndrome, I would like to invite Dr. Nancy Purbar. She is consultant endocrinologist, Department of Endocrinology and Diabetes, Bombay Hospital and Research Center, Jaipur. She has multiple publications, and as you can see here, she has multiple accolades to her credit. So over to madam.
Thank you, chairpersons. And at the outset, I would like to thank Team Essicon for giving me the opportunity to present here. So I'll be very briefly discussing the genetics of Turner syndrome. And at the end of the presentation, I just want to prove a point that it is more than just the missing X chromosome. This is the basic presentation outline. And after the elaborate discussion on the clinical features, I will start with the history of the Turner syndrome. It was first ever identified in 1930 by Professor Otto Ulrich. He described an 8-year-old girl with short stature, webbing, lymphedema, high arched palate, and other features. And it was in 1938 that Professor Henry H. Turner first published a case series of 7 girls with clinical stigmata of Turner syndrome. However, first genetic diagnosis was done through a karyotype. They found a sex chromatin negative in these girls, and which was the first evidence that it is due to X chromosome monosomy. So prevalence, as the chairpersons already described in the beginning, is around 25 to 300 live births. Though 90% of the fetuses with 45XO are aborted, these 99% are aborted. Just 1% of the patients are the patients that we see in the clinical practice. So the prevalence is similar across all the countries, and it doesn't run in families. There's slightly increased risk of Turner syndrome with increasing paternal age. And there's no difference in monosomy X incidence in assisted pregnancies as compared to the natural conceptions. And as Yashdeep sir mentioned, the median age of diagnosis is around 15 years. So the guidelines recommend, the definition is basically the absence of a partial or complete absence of one X chromosome that we are all aware of in the presence of typical clinical features. So these are the guidelines for genetic diagnosis in a patient with Turner syndrome. When should you consider a diagnosis of Turner syndrome? If you have any of these clinical features, the only clinical features and some of the combination of clinical features. So what diagnostic tools do we have after 100 years of diagnosis of initial description of Turner syndrome? We are dependent on the karyotype. A 30 metaphase analysis has to be done on a minimum to diagnose Turner syndrome. However, the recent guidelines now recommend that when a rapid test is needed, like for prenatal testing or in a newborn, other methods like microarray or FISH PCR can be used. However, chromosome analysis has to be done as a second-line confirmatory test. We have data that now says that SNP arrays are equivalent to metaphase cytogenetics in diagnosing Turner syndrome. So the guidelines also take care of this, that even newer methods like microarray and exome and genome sequencing can be used in the diagnosis of Turner syndrome in certain situations. However, confirmation with conventional cytogenetics is a must. Absence of one X chromosome is the classical feature in Turner syndrome. Then why do we dig into the genomics of Turner syndrome? Because there's a wide range of clinical manifestations. Patients, despite having the same karyotype, have a lot of phenotypic variability. There's a long list of clinical manifestations, as we can see, and all patients have a different age of presentation, and the disease severity is variable. Even in patients with 45XO karyotype, some will have cardiovascular manifestations, some will not have, and even till today, we are not aware that what factors exactly govern the clinical presentation in patients with similar karyotypes. Also, there have been multiple studies over the many years, which have been trying to establish the genotype-phenotype characteristics, but they have mostly been inconsistent. We are only reliant on the karyotype for diagnosing Turner syndrome, though it has multiple drawbacks also. Plus, if we understand the TS pathogenesis in details, only then we can have targeted therapeutic interventions. Even today, the management guidelines are similar for all kinds of Turner syndrome, irrespective of the karyotype or their genetic background. So initially, it was thought out to be out of a gene dosage theory effect. The haploinsufficiency of X chromosomes lead to the clinical manifestations, especially the short arm or XP chromosome. However, it is not just this, but there are multiple other mechanisms that work in the background. So looking at the cytogenetic landscape, this is the basic structure of the X chromosome with the short arm XP, long arm XQ, and there are two pseudo-autosomal regions, PAR1 and PAR2. These are important because these are biallelically expressed, and 15% of the genes from the pseudo-autosomal regions, they escape the inactivation, which happens in the X chromosome. So if we look at the various karyotypes, the most common karyotype that we see is 45XO, which is seen in 40 to 50% of the patients. Apart from this, the second most common karyotype that we find is the mosaic karyotypes, 45X and 46XX, or maybe triple X, or maybe 46XY also. Third most common is the isochromosome Q, and the other karyotypes are ring chromosomes. So we don't have exact genetic basis, but there is some amount of karyotype to phenotype correlation established. Like in patients with classical TS, there's more severe disease expression, there's increased all-cause mortality and increased congenital heart abnormalities as well as renal defects. While in mosaic forms, they have milder phenotypes, they have greater chances of preserved ovarian function and higher chances of spontaneous pregnancies. Patients with isochromosomes, they have increased incidence of hearing loss, autoimmunity, and congenital heart diseases. Those with ring chromosome have been found to be associated with learning difficulties and increased incidence of metabolic syndrome also. We should not forget that Y chromosome may be a marker chromosome, or 45X, 46XY karyotype is also found in multiple patients of Turner syndrome and should be evaluated if we see any signs of virilization during pubertal induction in these patients. Also important is to know that what karyotypes are not a part of Turner syndrome. So deletion, exclusive deletion of the XP22.3 region associated with the SHOX gene is not Turner's, but it is Lévy-Weill syndrome, because it is only associated with skeletal malformations and not other clinical features like cardiovascular or renal defects or ovarian dysfunction. So these are not a part of Turner syndrome. Also, deletion beyond XQ24 is not a part of Turner syndrome, and they've isolatedly been studied with premature ovarian insufficiency, and they don't express other features of Turner syndrome. I found this interesting paper from the West Bengal itself, and they studied 103 girls with Turner syndrome, and interestingly for them the most common karyotype was 45XO only, but the second most karyotype that they found in this region was isochromosome Q. So what do we know about the genotype-phenotype correlation? We have only limited evidences. The most consistent genotype-phenotype correlation established is for the skeletal malformations and short stature, which is the SHOX gene. SHOX gene is the short stature homeobox gene on the XP22.3 on the pseudo-autosomal region. And it is a transcription regulation, and it is expressed in the chondrocytes of the growth plate. So it causes short stature. It is associated with skeletal malformations in form of short fourth metacarpals and metatarsals, cubitus valgus, mesomelia, high arched palate, micrognathia, and scoliosis. Also, it is associated with sensorineural hearing loss. So other genotype to phenotype correlation, the second most convincing evidence is for the cardiovascular malfunction, which is TIMP1 and TIMP3 genes. So basically these are tissue inhibitor of matrix metalloproteinase 1, and TIMP1 is an X chromosome gene, while TIMP3 is situated on chromosome 22. So they are involved in the development of aortic valves, and they protect from thoracic aneurysms. So basically TIMP1 is a functionally redundant paralog of the TIMP3 gene, and in patients with loss of TIMP1 and presence of TIMP3 risk allele, the patients are at risk of developing bicuspid aortic valve disease. So basically it is a two-hit mechanism with loss of one gene, that is TIMP1, and the presence of TIMP3 risk allele on chromosome 22. So basically it is a combined effect of the X chromosome as well as the autosome 22. For other genotype-phenotype correlations with renal malfunctions, we have collectin amino acid transport regulator gene, which is present on XP22.2. For autoimmune disorders, there is interleukin-3 RA gene. Then for fertility problems, there are 3 genes which have been reported: CSF2RA, which is associated with intrauterine lethality of the fetuses, USP9X, leading to gonadal failure, and ZFX gene, which is also associated with ovarian failure. Interesting is to know about the KDM6A gene, which is associated with hearing malfunctions and also with multiple other things, including congenital hyperinsulinism, ovarian dysfunction, and even cardiovascular malformations. They've all been linked to KDM6A gene present on the short arm of X chromosome. However, we are not still convinced with the functional studies. The genes associated with the clinical manifestations are evolving day by day, and there are multiple candidate genes that have been implicated, but conclusive evidence is available only for SHOX gene even till date. So basically the phenotype in Turner syndrome is a mix of the X chromosome genes plus the epigenetic factors, including the protein folding, the DNA methylation profiling, as well as the RNA expression profiling. So it is these are the multiple factors determining the phenotype, and not just the missing genes on the X chromosome. So what are the emerging research and the future things we have is the epigenetics. Basically epigenetics includes all processes other than the DNA sequence. So there are the 4 mechanisms of epigenesis, epigenetic pathways: DNA methylation, post-translational histone modifications, nucleosome remodeling, and microRNAs and long non-coding RNAs. So we have evidence that there is widespread DNA hypomethylation in girls with Turner syndrome as compared to the girls with normal karyotype. And this hypomethylation is also associated with differential RNA expression in patients with Turner syndrome. Not only on the X chromosome genes, but also of the differential RNA expression of the autosomal genes. This paper, this is also from our country itself, from the IGIB Institute. They studied the transcriptome analysis in the fibroblasts of the Turner syndrome girls, and they found that there was a differential expression of the long non-coding RNAs in the 45 monosomic cells. Apart from this, a number of microRNAs and long non-coding RNAs have been implicated to coexist with the heart defects in the patients with Turner syndrome. So if we look at the regulatory genes, there is a network approach which is preferred over a single pathologic mechanism causing the clinical factors. So when we analyze the gene network analysis, there are multiple genes on the autosomes as well as on the sex chromosomes that are working together to cause any clinical phenotype. So we did an interesting study at the SMS Hospital, Jaipur, under the guidance of Dr. Sandeep Mathur sir. We did a chromosomal microarray analysis of 34 girls with Turner syndrome, and we found higher CNV polymorphs on chromosome 14 as compared to the X chromosome in these girls. So basically we recruited 47 girls, and then they were subjected to chromosomal microarray, and then further enrichment analysis was also done. So what we found was that there were multiple copy number variations on X chromosome in 29 patients, while on autosomes in approximately 97% of the cases. The most common autosome that was involved was chromosome 14 in 89% cases, with CNV gain either at 14q32.3 location or CNV loss at 14q11.2, or both these findings. Moreover, 92% patients simultaneously had CNVs on chromosome 14 along with CNVs on X chromosome. So role of autosomes cannot be undermined in patients with Turner syndrome. If we compare the CNVs on X chromosome and chromosome 14, all the clinical features like short stature, almost 88% patients also had CNV on for chromosome 14. All patients with cardiovascular abnormality had a X chromosome along with a chromosome 14 CNV. Patients with primary ovarian insufficiency, almost similar number of patients had chromosome X as well as chromosome 14 CNV, and similar for hearing loss and renal anomalies also. So then the enrichment analysis was done, which is a bioinformatic procedure, and what we found was a 67% of the interactome was overlapping with the interactome of the Turner syndrome genes, and the enriched pathways of the overlapping genes multiple pathways were enriched as stated in the table. So what we concluded was that CMA analysis in suspected TS girls, though it is not the first line test, but it can be done because it has been now we have data that suggests that karyotype is equivalent to SNP arrays as well. So we found that chromosome 14 anomalies were most uniformly present, more than the chromosome X anomalies, which is 89% versus 59%. And the network analysis of the genes implicated on chromosome 14 showed a 67% overlap with the X chromosome genes. So basically we proposed the concept of Turner spectrum disorders to include not only the patients with X chromosome CNVs, but also other findings on the other autosomes, which we found on chromosome 14. So I would like to end with saying that genetic basis of Turner syndrome is still evolving, and even after 100 years of the diagnosis of Turner syndrome, we are still not sure what genetic mechanisms are basically behind the clinical manifestations. Thank you so much.
Thank you, madam, for your elegant discussion. So I would like to request you to come here and join us.
Thank you, Dr. Nancy. Please join us.
I would have a request. I would request Sandeep Mathur sir to please throw his insights into the genetics of Turner syndrome, because sir has done a significant amount of work in this field.
No, be comfortable. We'll take your comment. Don't worry. I think I've reported about 23 cases of Turner syndrome about 30 years back. It was published in 2 international journals. We did karyotype, FISH, genomic-based chromosome analysis, SNP, microarray at that time. And I fully agree with that the most common abnormality was there in 14 chromosome, that was there. We were able to pick up the monosomy in SQ and trisomy in XP by doing genomic-based analysis. That was not picked by karyotype analysis. So I'm glad you have good data, and you must try to do something more for these girls. I will take your comment, sir. Dr. Gupta, I just have got one query from you is, when you should start growth hormone therapy, ideally, how to prescribe the different doses of growth hormones in these patients, what are the guidelines? Can you predict that which girl is going to respond better with growth hormone therapy if it is started early, maybe 3 or 4 years of life? Dr. Gupta.
Hello. So the current understanding on growth hormone prescription is that it should be ideally started around 5 years. 4 to 6 years is a window that has been recommended. But what is important that once you start, it is important to ensure that the continuity of growth hormone prescription is maintained. Because what I was highlighting in my presentation, that Turner toddler group, when initiated 2 years, there was a substantial benefit, but these patients are not able to sustain growth hormone therapy, and intermediate lapses were seen. So if there are intermediate lapses, you ought to lose some height gain. So 4 to 6 years, maintain till 14 years of bone age, or there is less than 2 centimeter of height velocity per year. That is one. Regarding that patients who is likely to respond, one, starting early, dosing is on a higher side. So rather than standard dosing of 30 microgram per kg, it's around 45 to 50, and even in some cases it has to be near 70. So on a higher end of growth hormone prescription, and some there are some suggestions that you can titrate on the basis of IGF, keeping 2 standard deviation above, or even in some cases of 3 standard deviation above. And the patient who start early, maintained properly, treated on higher dose, maintained and titrated on the basis of clinical response, coupled with the low dose estrogen starting at 11 to 12 years, these patients likely respond better to the growth hormone therapy.
Do you commonly encounter some of the side effects of growth hormone therapy while treating Turner's patient?
So I will say that my personal experience is less, because we have a dedicated pediatric endocrine clinic predominantly managed by Professor Rajesh, and most of the patients of growth hormone are in that clinic. But what I can quote is not from personal experience rather than literature, that there are no major concerns with the growth hormone therapy per se. But obviously you have to keep a watch on a metabolic risk factor profile, and if there are some metabolic musculoskeletal abnormalities like scoliosis or kyphosis, you need to keep a watch on that growing bones also. Otherwise, additional, don't think so there are any specific apart from metabolic perspective and kyphosis, scoliosis perspective, and slip capital femoral epiphysis is one again point that need to be kept, and other side effects are in general same with any indications.
Yashdeep, if I could ask.
I have seen, just wait, I have seen
Sir,
some
in continuation with his question.
No, I am asking him only, don't worry, please have patience, we will give you time. I've got some experience of treating these patients with growth hormone therapy. In one patient I encountered with the benign intracranial hypertension. See in one patient of carpal tunnel syndrome. The last query is that suppose some patient already have got severe scoliosis. Do you think the growth hormone therapy is going to worsen scoliosis or not?
Serious? Per se, there is not a contraindication for the presence of scoliosis, but obviously you have to watch. If it is like on growth hormone therapy, there is a marked deviation or marked changes, I think then there will be a point of concern. But just presence of scoliosis, I don't think so. But I will not say that I am 100% confident in stating what I am saying.
Sir.
Any question for me, or should I comment? Comment.
You want to say something? Some cases on genetic.
Oh yes, actually You know, in whatever genetic association we see in any endocrine disorder, it is reflection of actually technology developed and our phenotype. So 1957, the only technology to look for genome was karyotype. So somebody observed, he was the deputy director of medical services, and he said that Turner phenotype was associated with X chromosome defect. But what clinically more important, we have got so many patients who deserve the criteria to be screened for Turner syndrome. They have almost all Turner phenotype, some variation is there, but the karyotype is normal. What are they suffering from? That was the basic clinical question we started our strategy into it. Now I think we have data around more than 120 or 130 patients from our own institution, but we can add more if you have from your institution. Then we look for chromosomal microarray. This was a finer degree of karyotype. And the commonest defect was chromosome 14. Many patients who has Turner phenotype, chromosome 14 defect was there, but X chromosome defect was not there. That way, X chromosome is just an epiphenomena. Then we look into the in silico, not in a real patient sample, network of the genes. Because in genetics, if you go in reverse direction, you look at the phenotype, see what are the genes controlling that phenotype, what are the regulatory molecules that are controlling that phenotype, because there are so many things. This could be a gene product, it could be microRNA, it could be many things more. Once you look into it, then you make a gene network, which is second thing. A network, you look for the mapping. So when you look reverse, we find chromosome 14 gene network, and the genes which are implicated in Turner syndrome, there was a 67% overlap. The third point, which is raising serious question of X chromosome theory, is that patient who have, whole transcriptome down regulation of the genes, means genes which are not situated in chromosome, they are showing altered expression, and there is a genome-wide hypomethylation. So the interaction of X chromosome gene, chromosome 14 gene, and some else also, is multi-layer. Not only the actual physiology of a cell, which is playing a role in ovarian development or your bone development, but it is at the level of transcriptome as well. So what next step we are looking for? We will go for multi-omics profile, also Turner related cell. My request is, if somebody is undergoing cardiac surgery, please preserve the tissue. If some ovarian surgery is done for whatever reason, cryopreservation, please take one cell is enough for multi-omics. And we want to prove this network. And the regulatory molecules can be the future targets for progression retardation, because ovarian failure.
Sir, finish quickly, please. Others are waiting.
So I'm finishing it. So please preserve tissue. We should do omics profile and find new targets for intervention. Thank you.
Congratulations to both the speakers for nice work. And the work by the Nancy seems to be now mind-blowing. The things which we have been studying since our studentship, so the chromosome 14, and I think that similar type of the phenotype, which is observed in the male children, children also, the short neck or the apical fold, these should also be investigated for this assay, and whether this chromosome 14 can be the responsible for this kind of a picture that can again help.
So please submit a comment. Okay. Yes, please. Yeah, you are asking something. Sure. Any other queries from the audience? Any comment, questions? Okay, thank you so much, and I'm really grateful to both these speakers for giving nice job, and thank you so much.
So here we conclude our session on Turner syndrome. Thank you to the chairpersons and respected speakers. Now we move to the next prestigious session, Meet the Professor session. We have with us Professor Dr. Anuja Doctors. Just to reintroduce again, ma'am is an Executive Director of Women's Health Center for Clinical Innovation, Department of Gynecology, Pain Medicine, Director, Pain PCOS Center, Professor of OBG, University of Pennsylvania School of Medicine, Executive Director, Androgen Access PCOS Society US, Founder Professor in Women's Health, University of Pennsylvania. She has also been Associate Editor in prestigious endocrine reviews and ex-associate editor in JCEM. Madam, please take the stage. So, for presenting two interesting cases, I am inviting Dr. Nidhi Sheth, second-year resident in Department of Endocrinology, IPGM Hospital. She will be presenting the case, and the further session will be moderated by Dr. Madam. Please.
Thank you so much. So, starting with my first case, 26-year-old female, married since 5 years. Patient had complained of menstrual irregularities since menarche, since last 13 years, with severe progressive hirsutism since last 12 years, primary infertility, progressive weight gain, and alopecia since last 1 year. There was no complaint of acne, oily skin, or other features of virilization or defeminization. Also, there was no features of suggestive of hypothyroidism, hypoprolactinemia, or any cortisol excess. Coming to birth history, first order birth with low birth weight and a preterm delivery, and there was no history of excessive prepubertal weight gain or any history of salt wasting crisis. Coming to family history, her mother had also history of irregular cycles, hirsutism, and inability to conceive in initial years. The patient had two siblings. Younger sister has history of hirsutism with regular cycles, and brother of 20 years age with overweight. There was history of premature cardiovascular death in family. No other significant family history. The patient was diagnosed with PCOS and was started on combined OC pills in 2016. Coming to treatment history, for the period of 2016 to 19, she had taken multiple courses of combined OC pills. In 2019, even spironolactone was added. In 2022, it was changed to finasteride, drospirenone, ethinyl estradiol, and metformin. And since she was trying to conceive, she also received 3 cycles of letrozole in 2022 and 2 cycles in 2024. Coming to general survey, patient's weight was 56 kg with a BMI of 25 kg per meter square with a waist circumference of 82 centimeter and waist hip ratio of 0.89. On examination, blood pressure was within the normal range with grade 3 acanthosis nigricans with modified FG score of 26/36 and presence of hair in all androgen dependent area including the sideburn area. Patient had male pattern baldness. There was no clitoromegaly, breast atrophy, gluteofemoral fat atrophy, acne, or broadening of shoulders. On per abdomen examination, there was no organomegaly and no palpable mass. So this is the picture showing hirsute female. Coming to the biochemical parameters, there was presence of transaminitis with SGOT of 48 and SGPT of 117. The electrolytes were normal. FIB4 score was 0.77, fasting plasma glucose of 106, and HOMA-IR was 6.3. Coming to the hormonal parameters, thyroid profile was within normal limit. Testosterone was 82.14 nanogram per dl with androstenedione a little bit higher than the normal range with DHEAS within normal range, SHBG lower, and the calculated free androgen index was high. Coming to 17 OHP, the basal was 3.04 nanogram per ml with a stimulated 17 OHP of 4. And ONDST was suppressed. Coming to special investigations, ultrasound pelvis showing typical PCO morphology with increased stroma and peripherally arranged small cyst with the volume of 11 cc and 10 cc respectively. We had gone for CECT adrenal protocol to rule out CH, but the bilateral adrenals were normal. Coming to the workup for infertility, histosalpingography was normal. Husband semen analysis was within normal range. And to rule out any ovarian SOL, we had gone for contrast enhanced MRI pelvis, which was normal, except for the bilateral bulky ovaries. So we had gone for stimulated steroid profile by LCMS-MS method, which suggested 17 OHP of 2.36 nanogram per ml again, and with the total testosterone of 149 nanogram per dl. So the case in summary, this is a 26-year-old female with strong family history of hyperandrogenism, presented with severe PCOS with a classic phenotype A, with primary infertility, with features of insulin resistance and MASLD. Coming to my case 2, this is a 28-year-old female married since last 2 years who presents with infertility for 12 months, and she was referred by her GP. Patient had complained of irregular cycles, menarche attained at 13 years. She also had hirsutism similar to her family members. There was presence of acne before her menses. There was history of gradual weight gain and inability to lose weight. She had tried multiple naturopathic diet but failed. There was complaint of excessive tiredness, and so far no treatment was started. So coming to medical history, she was known case of asthma. There was no significant surgical or social history. Father was diabetic, and obstetric history, she was nullipara. Vitals were BP 140 by 78 millimeter of mercury with a BMI of 32, and modified FG score was 14. So the thyroid profile workup again was normal, prolactin within normal limit. The total testosterone was 58 nanogram per DL with a free testosterone of 8.5 picogram per ml. The DS was again within normal range. 17 OHP 1.8 nanogram per ml done in the follicular phase. As a part of infertility workup, AMH was high, 14 nanogram per ml, and pelvic ultrasound showing PCO morphology. Coming to the metabolic workup, fasting plasma glucose of 105 milligram per deciliter with a HbA1c of 6, total cholesterol of 215 with LDL of 140 and hypertriglyceridemia, that is 180, with a non-HDL cholesterol of 177.
So maybe we can pause here and sort of start with, so we've presented two cases, one just a very severe phenotype, and that's not what we commonly see. We commonly see the second kind of case. So in order to sort of just review the current diagnostic criteria so in 2018 we established the international PCOS guidelines, and we said that the Rotterdam criteria were the only ones we are now going to follow going forward, because there's good evidence to say that that supports all the long-term features that we've developed, and the long-term studies all corroborate with that Rotterdam criteria. So originally there was only LH to FSH ratio, then there was NIH criteria, then the Androgen Excess Society added their version, and then Rotterdam came, and it was very confusing both for practitioners and patients. And so I think the one good thing that's come out, and multiple good things came out of the international guidelines, but I think just firming up the diagnostic criteria. And then in 2023, when we did the update, we still said we are going to use Rotterdam. So what does that include? I think if you go next, so we have irregular menses, and I would wait at least the first 2, if not 3 years after menarche before counting those as irregular. There's really no harm. There's no rush in making the diagnoses at 14 or 15. We can treat the symptoms, but you can wait till 17 or 18 because sometimes it just takes a longer time for that hypothalamic pituitary axis to mature. So I would caution against rushing into considering this first criteria in a younger patient. And then in an older patient, it becomes much harder because some of them, if they come nowadays because of awareness, they're coming at 40 and saying, I think I had PCOS, nobody made the diagnosis, and then their periods are regular by the time they get older because that axis now starts communicating better. So at the two ends, I think it's really hard to use this first criteria, and one should be cautious. Always rule out anything mimicking, so thyroid, prolactin, premature ovarian insufficiency, like Turner mosaics, they can also present with irregular menses, some weight gain. So that needs to be ruled out with either a FSH level if you have day 3 numbers, or even an AMH level. So anything that mimics anorexia, eating disorders, so that hypothalamic amenorrhea. And so when you said that FSH, LH for no, you said AMH for fertility, yeah. So FSH, LH, I would get not so much for the ratio, because the ratio is going to depend on where that patient is in the cycle or just the spikes. But I would get it more to make sure you haven't missed anybody who is in sort of a premature menopause phase, because that has a whole other implication, right? So that's that first criteria. So it's not as easy as, oh, my periods are irregular. One has to take time. Nowadays, and I'm sure it's happening here too, but a lot of our patients on their phone, they have excellent records of they'll just pull out their phone and tell you when their periods were, and it's much easier to say, in the last 6 months, how many periods did you have? And they tell you, and it makes it much easier to document them. So the second criteria, which is clinical and biochemical, so that first case was overt, right, hirsutism, as well as the high testosterone. In the guidelines, we've said that the testosterone assays really are not well established for a female range. They're all more so standardized across the world for the male range. So we struggle a lot with female testosterone androgen assays in general, and hence we had put into use mass spec as sort of the gold standard. And I don't know how many, you can show your hands, how many of you have access for mass spec for total testosterone, or you're using ELISAs? More for mass spec? Yeah. And again, if cost is an issue or not available, I think recognizing that limitation. So it's usually going to be a little above the cutoff. And so that's where, if it's in the upper end of normal and you have the hirsutism, I would count that as your second criteria. But again, if you have access to mass spec, or calculate the free androgen index, you don't have to do free testosterone. You can, I think that's more sensitive, and you might get that as your second criteria. I find it very hard in our Indian patients when they say, I have hirsutism, because then mom has hirsutism, cousin, aunt, everybody. And is it just partly like we tend to have more hair than some other ethnicity? So making that difference, is it just familial hirsutism, or you have pathological hirsutism? And hence, I think getting an elevated testosterone helps, but we don't always get it because our assays are limited. And that's when I introduce a little bit of, maybe we are also not checking the right androgens, and over time, if we add the 11-oxyandrogens to the panel, we might pick up the whole spectrum. So those are the sort of caveats for hyperandrogenism. And the FG score, when you gave the case with upper arm but lower arm, so it's really midline hair, right, is the androgen sensitive hair. So when they say, yes, you know, I have hair on my legs, it's really upper lip, chin, between the chest, above, below, midline is the main area. And I would use that FG score sort of more strictly to get a better sense of where that distribution of hair is. And then the last criteria, I might think most people in this room will be happy. We've come away with that ultrasound. The reproductive endocrinologists, OBGYNs were okay with the ultrasound. Everybody else was like, this is too much work. So we can use an AMH instead of the ultrasound. AMH has the same limitations like the androgens. The assays vary depending on the manufacturer and their ranges, so you have to be careful about, there's no cutoff that we put in this guideline because of this variability in assays. So look at your own assay, and then you can use that upper one. If you get your first two, you're set. I think the third one is more to give them a sense of, is it a, you know, I feel we shouldn't stop at saying, yes, you have the Rotterdam criteria. We have to go the next step and say, what is your phenotype? Are you lean versus obese? Are you a reproductive versus a metabolic? Like, we need to go the next level now. We've been making this diagnosis long enough that we can get more sophisticated and say, what is your phenotype? This is heterogeneous. What are the problems? Not everybody is going to have fertility. Not everybody is going to have diabetes, right? So I think our patients read on the internet and they think they're going to get all these problems and it's the worst disease in the world, and that's not true. So if we can focus it down a little bit for them and tell them what phenotype and what it really means, it'll help in terms of the patient understanding their mental health and their approach to it. Not every patient with PCOS has infertility. Over half get pregnant on their own. They don't need our help because they're still ovulating. If the period comes every 6 weeks, 8 weeks, it doesn't mean they don't necessarily ovulate, but that's not what they're told. So I think, you know, same way now, they're very worried about cardiometabolic risk. Everybody, the minute you publish a paper on cardiovascular outcome, they all think they're going to get the heart attack or stroke, and we know that's not true. So I think just going that extra step and counseling the patient as to their phenotype and long-term risk. And of course, it'll change with time, but that's important at the first level. So we can pause here. Anybody has other questions for diagnoses before we move on to our next part of management? Yes. So the question is it necessary to measure HOMA-IR? So not at all for diagnosis. So that is your pathophysiology and why somebody might have PCOS and why they have the symptoms. It's not part of the diagnostic workup at all. So the metabolic workups. But once you do this, so is that on our next slide? Let's take a look. It's not, so the metabolic workup would include really an A1C. So we had OGTT in the first guideline. And then the feedback from across the world was too hard. Patient has to go and sit for 2-3 hours. They don't like the glucola. Do we really need something as involved? And I think the data is okay if you even do an A1C. OGTT will pick up the impaired glucose tolerance, and then the least is the fasting glucose. The insulin, we took it away from this updated guideline. Because as this audience knows, the variability in those levels is so much that the value was more anxiety for our patients and what to do with that number. The treatment doesn't change management, you're still counseling them. And that one number was causing more confusion rather than help. So I would say, if you just do your A1C, what do most of you do? Hemoglobin A1Cs or? Yeah, I think that's the best rather than going down the whole HOMA-IR pathway. Yeah. Yes.
Ma'am, I have a question regarding AMH levels. Actually, we have also conducted one of the study, PCOS study in obese versus non-obese PCOS. And what we observed that AMH levels were quite higher in the non-obese PCOS as compared to the obese ones. So is there a reason for that particular reason, or what are the clinical implications of that?
Yeah. So the question was AMH levels and the impact of so we know age-related they go down. BMI, as the BMI goes up, AMH goes down. On birth control pills, AMH is suppressed, as well as androgens. So if you have to do, if the patient has not come to you like for the first time with nothing and is already on a hormonal contraceptive, you have to at least stop for 2 months, wash out, and then do your androgens and AMH. Both of them rebound, and so it goes up. There aren't good normograms for BMI and AMH, and that's going, again, a limitation of that assay, is that the levels are lower, and with the bariatric surgery data, you see that the AMH levels again go up a little bit once that inhibition's removed, but we don't understand that pathway very well, why in obese patients you get lower numbers. Again, if it is PCOS, lower is just along that curve. They're not going to go into premature ovarian insufficiency, but it may be low enough that then you don't make your cutoff to make that third diagnostic criteria. Yeah.
Yeah,
Yes.
regarding the metabolic cardiac risk, vascular risk assessment, because Indians are not obese, they are basically non-obese, and that is primary area of investigation. We published a paper a couple of years ago in Dermatology Kargar that hair and syndrome, acanthosis nigricans, hirsutism, this reflects adipose tissue dysfunction. We demonstrated adipocytokine alteration. Second paper, which is actually under publication within Frontiers in Diabetes, where we have shown COCSIR, waist to hip ratio, because genetic association to develop diabetes, early diabetes, actually this data is from Queen Mary University with 1 lakh patient, that it is related to your waist to hip ratio. Genetic predictions up to that. And if it is associated with cutaneous signs of insulin resistance, acanthosis nigricans and acrocordons, they very well reflect underlying dysmetabolism, which is adiposity driven. So I think this could be a good sign for in future, if you want to plan some study, look for this physical sign. This will be very simple bedside sign for cardiovascular risk prediction. Thank you.
Yeah, and again, I think acanthosis nigricans has been recognized age-old in all our textbooks, but not everybody is going to have it. And the question is that your most severe phenotype that has this cutaneous end has seen enough,
Yeah,
for a
acrocordon
longer
indicates
duration.
more severe degree of insulin
Yeah,
resistance, though it
yes.
was measured by
Correct.
Humai, yeah.
Yeah.
And we are doing actually metabolic disease scoring based on the triglyceride and all these parameters, BP and all these things, and cluster disease number. It is acrocordon indicates more severe degree of adipose-driven pathophysiology. So if there is a waist-tube ratio is high, because the individual who don't have a predisposition to abnormal waist-tube, they have generalized obesity, they develop cutaneous signs of insulin resistance, but then don't have the disease association. For disease association, both are required. Abnormal waist-tube ratio as well as cutaneous signs. And acrocordon means more severe degree of dysfunction. This
No,
is the thing
I agree. Then again, I think the BMI, it's sort of been all artificially created, right? This height and weight association and what the cutoff should be. The waist-hip ratio, at least for PCOS, now that the adipocyte dysfunction is just again coming back into prominence and we are understanding the mechanism, it's not just insulin resistance, but also dyslipidemia is all tied into it. And then chronic inflammation comes, adiponectin, leptins, all are coming from the adipocyte. And a crude assessment is waist-hip ratio. I guess imaging would be better, but that's not what we are going to do for everybody. So I totally agree that I think we have to come away from BMI and put it on the scale. I think we are at a place where we want to diagnose everything early though. So the cutaneous manifestation still is the more severe later. So the question is, how do we pick this up in your 21-year-old, early 25-year-old? Waiting for the acanthosis becomes later, and that's why I think we see less of it, because we are managing much earlier. So at least in my practice, I'm seeing less and less of acanthosis than 20 years ago, maybe because we are on top of these things. But all valid points, yeah.
There is a subset which has only adrenal hyperandrogenism, or that is not accepted now, and are they any different from the ones who have ovarian? And some of them don't have a biochemical hyperandrogenism, just manifest with the features. So are they sort of different metabolically, reproductively?
Yes, all good questions, and we can only talk about diagnosis for the whole hour because of this whole challenge. So within hyperandrogenism, there's clinical and then there's biochemical. And by the diagnostic criteria, if you have only clinical, that's okay. And I think it's okay because our biochemical isn't so good at picking it up. Our assays are limited. I think we'll get to a point, hopefully, where it'll all match up. Unfortunately, we had a whole meeting with the CDC last year, and we said you have to prioritize androgen assays. And now, as you all know from the news, the CDC is not very functional in the US. So I don't think our androgen assays are going to get any priority, but we'll continue to fight for that. So right now, it's crude and limited that we do use only clinical, but that's okay. And then in the biochemical, the newest guidelines, we said testosterone really is the gold standard, because DHEAS is sort of less sensitive in terms of the association. I think if we think about the pathways, the adrenal precursor, ovarian precursor, if there's adipocyte dysfunction, may contribute to the androgen milieu eventually by that diagram that I was showing you through AKR1C3 and conversion. We just don't, they have to have enough precursor. And so just the DHEAS is also just one part of it, and it's an end of that entire pathway that you're measuring. So if you get irregular menses and a high DHEAS, no hirsutism, that's challenging. If you get the hirsutism, you have your diagnosis, yeah. Yeah, and it's very rare. I know you showed that you did the CT scans. I don't end up doing as many CT scans. My yield is so low to find. Usually I pick up an incidental finding on the CT in the adrenals. I rarely find a hyperplasia, something that's secreting the excess. And again, you might get more of a referred population, but my yield is low. So I've been raising the cutoff more and more to ordering the CT scan because, again, expensive, it's involved, and I don't do as many of those, and haven't missed out as much.
Ma'am, I have a brief question, just to, in continuity with what Sir said. Is there any role of new, like direct adiposity assessment tools which are available, like I'm talking about bioelectrical impedance tools which are available? and at least in the medical college setting, can we go ahead with those fat assessment?
Yeah. And I think you have to, it's the practical part of it. How will it change what you're doing? Right? I think the whole idea is we are trying to find things earlier and earlier to help this young population. But if it's not changing and you can do it through a waist circumference, do you really need to do the next steps? So I think they're okay for a research question. HOMA-IR is also okay for a research question because it's much harder to do the glucose and insulin clamps. So a lot of people will do Matsuda index, HOMA-IR, and that's all fine for research or an impedance testing. But I don't think it's practical for clinical. Yeah. All right. Do we have time to go on?
Excuse me, ma'am.
Yes.
One question.
Yeah.
Role of metformin in lean PCOS, whether it is recommended, patient has normal glycemia. So many are doing this, they are prescribing metformin only as a first line therapy.
So that leads us to our first thing here, lifestyle modification, diet, exercise, and behaviors for both of those patients. So you have the severe patient and then the mild patient. Our mild patient was obese, and your question is if the patient is lean. Okay, so metformin has been used for what, almost 30, 35 years for PCOS. It came from your diabetes field, and we just co-opted it into sort of the PCOS field because the underlying pathophysiology was insulin resistance. But the clear data in terms of treatment and prevention, comes from all the diabetes prevention trials. Those were patients included were those with impaired glucose tolerance. It wasn't patients who were normoglycemic. So I don't think we have a lot of data saying in the normoglycemic patient, let's give metformin, and then if you give it for how many years, 10, 20, we're going to prevent heart disease. We don't have that data. So I feel, and in general, I think we have now begun to feel we have been over-treating these young girls and patients for so many years with no end goal and end point. And you know as well that everybody who has IGT doesn't convert either to diabetes. They just stay, some of them. So this has been hard. I think we just have had no treatments for PCOS, and so we've used metformin for too long. I think if we switch and change to adipocyte management and dysfunction and start getting newer medications, maybe that is a better targeted way of doing it in the lean patient. Yeah, so in the lean patient, I'm not using, and in the guidelines we said overweight or obese. Again, knowing our limitations for BMI, yeah.
And role of myo-inositol.
I think you have a talk coming on that next, so we'll wait for the expert to tell you that. It's a supplement which there's even less information than metformin. But I won't take away Dr. Chitra's talk.
Thank you, ma'am.
Yeah.
Ma'am, it's a brief question. So whenever, yeah, ma'am.
Yes.
Yeah, okay. For any patient, when we think of polycystic ovarian syndrome, we know that we have to exclude other causes. So what's the prevalence of non-classical CH in India now? I think in our day-to-day clinical practice and last 15 years of practice, we have discussed many aspects of NCCH. But I think the percentage is extremely low, and the genetic variations are also very, very low in India. So, but if there is a little bit extreme variety of hirsutism, we usually do 17-OHP, and if there is an equivocal 1.9, 1.8, we go for ACT stimulation test and then 17-OHP. But I think we have to reconsider whether NCCH is at all so much prevalent in Indian settings, whether the mutations are really exist, because there is the Cosmo city and Cosmo countries, there are many variations in the genetics. But from my experience and from experience from my teachers and mainly from our friends, that probably the NCCH doesn't exist to that extent that we have to exclude NCCH in every cases, particularly in the extreme variety of hirsutism. Your take on this message?
No, and thank you for bringing that up. So in the most recent guidelines, we dropped 17-hydroxyprogesterone as the screen, And then we put the qualifier for DHES for the same reason, because there are only pockets in the world
Yes.
where congenital hyperplasia has a high prevalence. And as a screening test, as you all know, you need a certain prevalence, otherwise it's just not effective to have that screening test. So we have dropped it out, and you can, again, in a academic setting, when you're teaching your trainees, you can bring it up or decide if your referral population and you get it. But I don't see it as much as well. We do see it in New York. There is the Orthodox Jewish population. They have a much higher prevalence, the Ashkenazi Jew. In Philadelphia, I don't see it a lot at all. So I have been following with what we put in the new guidelines, that we haven't been doing it. Yeah, so good point. And I think we have to make it simple for everybody, right? Like, we've had these things in for so long. I think we can start modifying that. The DHES, the assays will get better with time, yeah.
Actually, there's a lot of heterogeneity in PCOD populations. We had around data of 400 patients, and we did some deep phenotyping, looking for adipocytokine markers, to anthropometry, to cutaneous signs, to adrenal steroid profile, but only 17 OHP DHES and androstenedione. We actually use machine learning model to subcluster, and we find 3 subclusters, and LHFS ratio also. So there were 3 subclusters, one which has predominantly metabolic syndrome-like picture, not metabolic syndrome, dysmetabolic picture. Cutaneous signs and insufficient, high HOMA-IR, as well as central obesity. There was a spectrum who had actually borderline high DHES, not crossing the limit of normal. A test we learned from my teacher, Dr. Amini in AIMS, dexamethasone suppression look for adrenal profile. Interestingly, in a subset of patients, DEXA lead to more than 50% fall in testosterone level in the same assay, in the same lab. But in so-called insulin-resistant group, there were no fall in dexamethasone, testosterone with dexamethasone suppression test. So now we have taken a project of deep phenotyping, right from MRI body fat analysis, ectopic liver fat. For India's most important ectopic liver. You attend my talk at 12:30 in another hall. So we are doing this. We are doing adrenal steroid profile by LCMS method, and we are also doing SCG stimulation test, and also doing DEXA test. Do you think it is worth subcluster the patient according to his adrenal in origin, so they don't cross the diagnostic criteria of CH?
Yeah. I think the adrenals were a big part of PCOS, then it all became more ovarian, and now that interest in, is there an adrenal component to these androgens, is again coming up. It's coming up more because I think we have assays for these other steroids. So our data, which I didn't show you, so 11-oxy ketotestosterone, which is the potent one, and the hydroxytestosterone, those levels are elevated in PCOS patients, but again, not all. So you're going to get all these subtypes, like the one you're describing, and these 11-oxy androgens drop very nicely with birth control pills.
Yeah.
But if they're coming from the adrenal, I would have thought the birth control pill wouldn't drop them, because it really works on an ovarian mechanism, but there are some LH receptors on the adrenals. So I think a lot more to understand about all these different phenotypes, those being suppressed by steroids, those being suppressed by OCP, birth control pills. So more to be done. I don't think we have the answer, but keep doing it, because all our populations are different.
Yes.
And we need this data to understand what that androgen milieu is.
Yeah. Thank you.
We face a lot of difficulty in having reports from radiologists. So can you elaborate PCOM, that is follicular number per section, follicular number per ovary, and volume? What should be the correct diagnostic criteria?
Yeah. So, I never thought somebody is going to ask the ultrasound question. So good, I'm glad you asked it. So with the ultrasound criteria, it is the volume, which is the easiest answer to give. It's greater than 10, and that's been well validated, and it's a good high enough cutoff that you're not going to get as many false positive. If the radiologist, what I see with reports from here and also some parts in the US, they'll give only 2 dimensions. So at least the basic, if you ask them for 3 dimensions, then it's your 3 dimensions multiplied by 0.52. I always just land up calculating the volume, because they don't give it in the report. So that's the easiest. The antral follicle count, much harder. I think the infertility doctors, reproductive endocrinologists, we are more familiar. Even our radiologists don't give that to us, but that's a count of more than 20. So that becomes a harder one. And so maybe AMH is better now rather than depending on that, or then use volume. So one of those two would be okay for the PCOS morphology. Yeah. Yeah. So transabdominal, then you just go with volume because the accuracy of counting follicle counts is much harder with transvaginal. So transabdominal, I would just use volume and at least get the radiologist, when you put the order in, say, please count 3 dimensions, we will do the rest of the calculation. But when they give you 2, which is what I see on so many reports from India, then that's hard. Then I have the patients redo the ultrasound. I can't use that, yeah. All right.
Okay.
Do we have time or are we done?
Yeah, ma'am, the last slide.
We're going to just summarize. How much time do we have? Who's keeping the?
Time
It's done, no? Yeah. So go to the very last slide.
Yes, ma'am.
And so we didn't really, this was supposed to be a reproductive metabolic session, and we didn't get time to talk about the fertility part, but so just to very briefly summarize, the weight loss or management of cardiometabolic risk prior to pregnancy is important because we talked about how pregnancy is high risk. So if we can get their sugars under control before they're pregnant, their blood pressure under control, they're going to have a lower risk of preeclampsia, gestational diabetes. And talking about that and not having that urgency of let's try to get pregnant today or tomorrow. And the first line treatment is letrozole as compared to Clomid, about an 8% difference in per cycle success rate. Oral medications in general work well. They work well if you combine with metformin. I wouldn't do metformin alone because it's not going to get them to ovulate every month. So then the success is lower. So if you want monthly ovulation, you need like the letrozole or the clomiphene. And then very few people actually need to go all the way to IVF. And then we talked about screening for cardiometabolic risk. And please refer to the 2023 guidelines are I think there's got good international consensus. We had good representation from India. So there was enough of these points got brought up about BMI, et cetera. So these are good guidelines to use as well. All right. Thank you so much for all the questions. This was great.
Thank you, ma'am. Thank you for this comprehensive and really engaging discussion on the case. PCOS is a condition that we frequently encounter. Thank you, ma'am, for sharing your valuable expertise on this case. Now we are moving on to our next session, which is on women's endocrine health. And to chair the session, I'd like to invite Dr. Guru Raja Rao and Dr. Arundhati Dasgupta on the stage.
So good morning, and after that very extensive, wonderful session on PCO, we'll be basically extending the discussion forward because we'll be talking a little more about PCO. There is so much to discuss about PCO, whether you're talking about the cardiometabolic or the androgenic aspect or the fertility aspect, the psychological aspect. There's so much to discuss actually about PCO. So we have our next speaker, who is Dr. Preeti Dabadkau, and she will be talking about the very important area of the ovulation induction in PCO, looking at the current perspectives. Dr. Preeti, ma'am, please.
Good morning. It's difficult to fill the shoes after you've heard Dr. Dokras. And I think she has a flight after my talk, so maybe with the permission of the chairpersons, if there are any questions, she may answer rather than me because she's an expert on reproductive endocrinology. So at the outset, I thank the ASCVD organizers to give me this opportunity. And let's just go through quickly about the current concepts coming from the history or coming from the basic of pathophysiology of anovulation in polycystic ovary syndrome. So this is what my outline of my talk is going to be. And we know that the global estimate of polycystic ovary syndrome is 1 in 10 persons. And the classic description is oligomenorrhea, anovulation with hyperandrogenism along with PCO morphology. It's a very heterogeneous condition, and at the outset, I would like to say that we should describe the phenotype very clearly, because you heard earlier Dr. Dokras speaking about that there's a reproductive phenotype and there's a metabolic phenotype. And the results which we have seen for all kinds of studies, be it in metabolic therapies or reproductive therapies, everything depends upon what kind of a phenotype this patient has. And in majority of the studies, the phenotypes are not described. So you can't put the results in perspective that if your patient falls in a particular phenotype, say the patient has a classic phenotype, so what kind of a drug is going to help? So if all the studies henceforth have a clear description of the phenotype, I think it's going to help our patients more than just doing studies at random. And it's actually a classic situation where one size fits all cannot be applied. And as we know that about 70% of all chronically anovulatory PCOS women do get pregnant. And we have beautiful data from registries from Sweden, Finnish cohort, who have shown that the pregnancy rate is probably they get pregnant, the number of pregnancies by age of 26 at least equal in PCOS and non-PCOS. If these women are followed long term, the fertility rate and the average family size may be smaller in women who have PCOS than non-PCOS. But doesn't mean that every woman who has chronic anovulation would require treatment. Just a brief about what happens in the follicular development and where do we have to hit in these women. Normally what happens is that from the early stages of follicular development, the antral follicle will go into becoming a pre-ovulatory follicle. And then the LH surge will occur after it is a Graafian follicle and it will rupture. In PCO, what happens is there is an imbalance between the LH and FSH. So you have high of LH, there is low FSH, so there is a follicular arrest and normal development of the follicle doesn't go on to the pre-ovulatory phase. And the hyperinsulinism which is there, it increases the androgen production. Intra-ovarian androgen leads to follicular arrest, as well as the hyperinsulinism makes those ovarian follicles more responsive to LH and produce more androgens. I'm sorry, what has happened? Have I done anything or it's from your end? Okay. So the basic principle of ovulation induction would be to increase the FSH so that the follicular multiplication and development is there, or the second would be to decrease the insulin levels by using metformin or decreasing weight so that the hyperandrogenic state is decreased and the response to FSH is better. So this cartoon I have taken from the international guidelines where they clearly say that polycystic ovary, once you've diagnosed, then there should be an optimal preconception care because all these women are at a risk of developing a lot of pregnancy complications. So that should be addressed before we go ahead and counsel them for fertility. And probably if they have lost weight, they have controlled their hyperinsulinism, they may spontaneously ovulate and you may not require treatment. So 5 to 10% weight loss in these women has shown to have ovulation. So that is the first step or the first line management which we should do. And after that, once we have established that in spite of all this, still the woman is not ovulating, then we go ahead and use various ovulation induction agents. The first line treatment in these patients is letrozole. So and then comes, once there is failure to letrozole, then or clomiphene along with adding metformin plus minus. If there is a failure or the patient doesn't ovulate, say to a maximum of 6 cycles, then we go ahead to gonadotropins. If the gonadotropins even fail, then third line management is in vitro fertilization or assisted reproduction technologies, which is beyond the purview of us endocrinologists. So I'll stick to only ovulation induction agents, a little bit about gonadotropins, and a couple of slides about bariatric surgery and anti-obesity measures. So coming to the 2 ovulation induction agents which are available to us, the first panel shows about clomiphene. And clomiphene has been there for WHO class 2 anovulatory ovulation induction since 1960. And how does clomiphene work? Clomiphene is a selective estrogen receptor modulator. So it has both estrogenic as well as anti-estrogenic properties. So when it acts on the hypothalamus, the negative feedback from the estrogen is inhibited and the FSH rises. And we know from the previous ovulation slide that if you increase the FSH level, the follicular proliferation and maturation is better. So that is how clomiphene acts to increase FSH and induces follicular development. But there is a flip side to this anti-estrogenic activity. Because clomiphene has a longer half-life, it accumulates in the body, the rise in FSH is chronic and to a very high level. So it leads to multiple follicles being developed in the ovary, and that is why you could have multifollicular development and multiple pregnancies with clomiphene. The other adverse effect of using clomiphene is, since it is anti-estrogenic, it has a detrimental effect on the endometrium. So even if a follicle develops, even if you have ovulation, ovulation rates may be there, but conception, pregnancy, and live birth rates are lesser as compared to the success in ovulation, which you may see with clomiphene. Contrasting to this, letrozole, which is an aromatase inhibitor, it has a shorter half-life. It acts only as conversion from androgen to estrogen. So there's a precipitous fall of estrogen levels in the blood, which removes the inhibition to the hypothalamus, and you have increased FSH. Along with that, the FSH levels are maintained for a short period of time because you give both these drugs only for 5 days. So the FSH levels are not continuously high, and you see more chances of monofollicular development with letrozole. And in addition, the benefit is that it doesn't have negative effects on the endometrium. And once you withdraw letrozole, the concentration of intra-ovarian androgens rises. And we have to understand the early development of follicles, the primary and secondary follicular development, those preantral, they are very much androgen dependent. High androgen will lead to better development of these follicles. So letrozole works both ways, doesn't have the endometrial side effects, has a shorter effect on FSH, as well as improves the androgen, so the follicular growth is better. So letrozole you use mostly in 2.5 milligram, going up to 7.5 milligram. Usually once the success is seen or you document ovulation, you use it for 3 to 6 cycles. 7.5 is the maximum dose. But there was a concern about teratogenicity way back in 2005. And some countries, it's still of an off-label use, but large data which has been there doesn't show that letrozole has any teratogenicity, and it has been proposed as a first-line management for ovulation induction in these women. This is a comparison, various parameters of ovulation induction between clomiphene and letrozole. This data I've taken out from the meta-analysis synthesized for the 2023 guidelines. And you can see in both ovulation induction, conception, and live pregnancy, live birth rates, and even pregnancy, all are much better with letrozole, and it convinces us to use letrozole as the first line management as an ovulation induction agent in PCO. There are, as we said, that if letrozole is better, clomiphene acts in a slightly different way. is there any situation or is there any data to tell us that can we combine letrozole with clomiphene? Because they may have an additive effect, but they're not very good studies or large number of data convincing us to use a combination. But whatever I could get in literature was that there was higher rate of mature follicle formation, ovulation rate, when a combination of clomiphene with letrozole was used as compared to single agent. And there were similar number of pregnancies, so maybe that negative effect of clomiphene dominates even when you're using it as a combination. Incidence of adverse events were similar, so still the jury is out whether we should combine them or not. There are studies on using graded doses that you compare 2.5, 5.5, 7.5, but they are all small studies in non-English published literature, so probably there's a bias. Again, in some they show that there is a benefit when you combine it with gonadotropin, but again, the data is not convincing of using it as in combination. So we come back that it's still moderate dose letrozole still remains the most effective strategy for ovulation induction as a first-line therapy for improving pregnancy in these women. If the woman does not ovulate on letrozole, then what do? We move on to a more expensive, more challenging as well as monitoring intensive therapy as gonadotropins, and definitely more expertise is required when you use gonadotropins, more intensive ultrasound management, and the cost of therapy, as well as you have to understand that there would be implications of multiple pregnancies, so you should have a high index or a low threshold for cancelling a cycle if you see multifollicular development when you're using gonadotropins. There is no difference, or at least literature doesn't show any difference between urinary gonadotropins, HMG, recombinant FSH, or highly purified gonadotropins. All have nearly the same kind of success rates for ovulation, conception, and live birth rates. Prior to this, you can have generally there are various protocols which are used. I'm not going to go into the details. One is a low dose step-up protocol where you use from 75 to 100 IU and gradually build up to 150 IU of FSH. Or there is a step down where you use 150 for 4-5 days and then gradually go down to a lower dose. Either of the doses are effective, but generally proposed is a low dose step-up gonadotropin protocol to optimize the chance of a monofollicular development. So once we have seen ovulation induction agents like letrozole, clomiphene, and gonadotropins, what is the status of anti-obesity measures like medical therapy or surgical therapy? We know that obesity causes hyperinsulinism and it's a risk factor for hyperandrogenism. And way back in 1995, studies have shown that even if you lose 5 to 10% of your original weight, ovulation has been documented. There are beautiful studies from Rob Norman's group from Adelaide where they have shown that 5 to 10% weight loss causes ovulation. But is that enough to have conception and live birth rate is not very clear. And now with the surge of anti-obesity drugs, which have a significant weight loss, improvement in metabolic parameters, what is their status? Till now, there are no studies showing ovulation, at least whatever literature search I did not find studies showing ovulation rates, conception and live birth rates by using all these anti-obesity measures. So probably studies are ongoing. People need to analyze their data and present and publish. In animal models, there is some mention of deleterious effects on gonadotropin ratio and uterine endometrium with the use of GLP-1 analogs. So this also needs to be borne out in human studies and clinical data. But bariatric surgery, we know, has been there even before GLP-1 analogs. And there is data from bariatric surgery which shows, this is a study published in Lancet last year, where this was an RCT comparing PCOS, 40 PCOS women with medical therapy versus bariatric surgery, either sleeve gastrectomy or the stapling. And it did show that 4.1 incidence of ovulation rate over 52 weeks in women who underwent bariatric surgery as compared to medical therapy in the form of lifestyle intervention and psychosocial management. And the response was seen as early as 8 weeks in the surgical group. So this was documenting ovulation events. Study published in JCM where they compared women who underwent bariatric surgery, comparing PCOS women versus non-PCOS women who underwent bariatric surgery. And they did show that bariatric surgery, the pregnancy rates, live birth rates were very similar to the obese women, non-PCOS obese women who underwent bariatric surgery. The data is retrospective, so it has to be taken with a pinch of salt. And there's a large retrospective population-based cohort study where they looked at around 15,000 women and who underwent bariatric surgery, of which nearly 150 women had PCOS and rest were non-PCOS. What they found was that women, PCOS women who underwent bariatric surgery, the pregnancy complications of PIH and GDM were significantly lower in that group who underwent surgery. So probably bariatric surgery helps in the metabolic ones. We need to have long-term data to see how much ovulation it improves as well as live birth rate it improves. The thing which we have to remember with bariatric surgery is that patients have a lot of micronutrient deficiencies which should be looked into, and what effect does that have on the fetus, intranatal development of the fetus and future development of the child, how is that affected? And the women have to have a constant wait for at least a year before you advise them to go ahead and have fertility options. So it's not a simple thing that you just lose weight and go ahead and get pregnant. All these things have to be factored in, counseled and looked into before it can be taken up. So just a brief mention about what is the role of metformin. Metformin, all of us endocrinologists are very aware, sort of a wonder drug. It decreases proliferation, it improves metabolism. So something like vitamin D, we use it everywhere practically. So metformin is an effective and a safe insulin sensitizer. It improves metabolic features, especially in women who have IGT, who have actually obesity or have glucose intolerance. Probably it's a good drug to be used there, or who have documented insulin resistance. In a very select group, it may regularize cycles, but the use of metformin alone doesn't improve ovulation, doesn't improve the conception rate. Combination therapies probably yields better fertility outcomes in women with PCOS. And as we came to know that there is a metabolic phenotype, probably combining other drugs in those metabolic phenotype may give you a better result. And individual factors like BMI, AMH, and insulin sensitivity appear to influence response to treatment or combination to metformin. So to conclude, all PCOS women should have a lifestyle intervention, which is a must, a bottom line, because it just doesn't improve their metabolic features, but helps them to have a better pregnancy, a safe pregnancy. Letrozole is the first line to be used if not contraindicated, meaning that if off-label use can be permitted in countries where it is not. And as I said, there are many unanswered questions still in this group of women, that how do the results matter with the various phenotypes which we know of PCOS? Are there any prediction models to say that these are the women who will respond better, so we give them a hope? Ideal number of cycles with letrozole and clomiphene, with or without metformin? And is the gonadotropins, which is, or aromatase inhibitors, which is the best drug to be used in drug-naive patients, and various combination therapies. So I'll leave you with more confusion than answers and end my talk here. Thank you for a patient hearing.
Thanks, man, for that wonderful talk. I think questions we are going to take later.
I think we can take the question. I think Dr. Tejal is waiting there.
Yeah, just one question. So, two questions really. So this is one phenomena which happens is that most obese women with PCOS, many times they go to the gynecologist and they're told go lose weight and come back. And often they lose years and years struggling to lose weight and not being able to. So the question is that what is the direct effect of BMI on the live birth rate, and how much of weight do they need to lose before, I mean, how much of weight loss improves the outcomes for PCOS women? The second question is with the newer GLP-1 analogs and the dual GLP-GIP, is there any data where a short-term 6-month, 8-month therapy, weight loss, and then going for pregnancy, and how does that help with fertility and the live birth rate?
I feel the second question is easier to answer because I tried to dig into literature looking at these drugs because they cause significant weight loss.
Correct.
But I didn't find, maybe Anuja would be able to help us in that matter.
Yeah, so there are studies. I think it's wrong to say to the patient, go home, lose weight, and come back. You have to give an endpoint, right? And the endpoint will change if the patient is 26, if she's 36. It's very different. And even if she's 36, if they want one kid, you may be okay, but if they want 2 children, like, you know, you have to think about that long-term fertility journey. So how much weight loss is the main question every patient's going to ask you. And I don't know where that number 5 to 10% is in our literature everywhere. It's really not based on any specific studies. So the way I would break it down is first say, is there a cardiometabolic risk? If they're diabetic, pre-diabetic, hypertensive, it's very clear. These are the things we need to manage, either with weight management or medication. So that's, I think, a given. And then, if they lose some weight, will they start ovulating? Because that's your second thing. There's no magical weight because we realize BMI is so crude. So there's no weight to say if you come to 29.8, you're going to be better than 30.5. That just doesn't work, and we all recognize that. So our study, our PCOS, showed that those who lost weight still needed Clomid later. So 4 months of intensive weight loss, then clomiphene, and that time it was clomiphene was first line, had better ovulation and live birth rate. So it's not that they won't need medications, they may just be better responders. So you get a little weight loss and then start ovulation induction. In the larger IVF studies, they found no difference, but when they looked at the PCOS subgroup, spontaneous pregnancies while waiting for IVF increased. So there is a benefit, but it'll come in different ways. It'll come either spontaneous, it'll come in response to lower doses of letrozole, lower doses of combinations. But you have to give your patient a timeline. You can't just say, go away, come back another day, because that's very hard and we may miss the window in some older patients. And their second question with GLP-1, so the data that, there are very smaller cohort studies that are there. In the PCOS population, it regulates menses as the weight comes down. It's very similar to bariatric surgery. We see, I can tell you from my own practice, androgens drop, weight drops beautifully, as you all know. Patients are extremely happy they finally have a good drug that's helping. And it's that titration. It's very critical that we titrate slowly and not rapidly. That has been the bigger issue, that the prescriptions are given this dose 1 month, second dose. There's no need to escalate. If they're losing weight, let us wait and let's be cautious, and then they'll tolerate it better. Yeah, so we're happy that there are GLP-1 receptor agonists on the market. I think it's going to help our PCOS population a lot. When do you stop it? So that's the whole issue. It's 2 months, these are animal studies, and so the drug company tells us 2 months prior to. We have narrowed it down to, because the patient's not going to get pregnant the next month. It's going to take them another 5, 6, 7 months, a year, and there's a whole rebound. So we have now been saying 1 month prior to with the tirzepatide, the newer, the combination, I don't think any of these cross the placenta. We just need data. It's a big molecule. So I have seen some of them say with a positive pregnancy test you can stop. The drug company is not, pharma is not going to tell us that. They haven't included women who are trying to conceive in any trial. They tell us to use 2 contraceptives in a trial, birth control pill plus a barrier. So it's very hard to get this data. But the data from the 2 registries, which I think you showed, there's a Scandinavian and there's one more registry now saying that inadvertently patients who've been on this, birth defects are not higher than the diabetics. So that's the most we know so far. I think that we'll know in another couple of years. Everybody's collecting this data, yeah. So at least if with a positive pregnancy test we can stop, that might be a win-win. Yeah, that will be good.
Thank you so much, ma'am. I think we can just take one more question. Dr. Chitra.
Thanks, Dr. Arundhati. Dr. Preeti, if I recall correctly, I think letrozole is off-label use in pregnancy in India, but with accumulating data that letrozole is more effective than clomiphene.
Yeah.
What's your take in your clinical practice? Do you go ahead and use it, or are you going to be mindful and not use it, and maybe start with clomiphene and switch to letrozole later?
We are using letrozole. Yeah.
Okay, so should we then maybe as a society maybe
probably
reappeal for a reclassification of the medication so that it's not off-label, because there are also legal implications?
A lot of people are using letrozole. I think gynecologists are using it universally, letrozole. Yeah. And I didn't touch on myo-inositol because your talk was after that, so that was totally missed from my talk.
I will cover that.
Thank you.
That was a very enlightening thing. So next.
May I ask the last question? We'll have to take it. We're actually running short of time, so yeah, maybe
so
next.
the quest for the best, still has not been put to rest when it comes to therapeutic options for PCOS. So we have got Dr. Chitra Sullivan talking on myo-inositol. So, quite much hyped molecule, like whether it lives up to that mark, like what is the evidence? So let's see. Over to Madam.
A very good morning to everybody here. Extremely happy to be in Kolkata at all duration, and I never miss a chance. Thank you, team organizing, ASCVD 2025 for the invite, all my teachers, and everybody here. I'm going to be spending the next few minutes addressing myo-inositol for PCOS. It is really effective. And this is an important conversation, primarily because the interest in this molecule for management of PCOS is probably more from people living with the condition than maybe from healthcare professionals. So this is the outline of the conversation. We'll talk about what inositol is and why we're talking about it at all, what its connection with PCOS might be, biological plausibility, and we'll review all the evidence available and then what the guidelines recommend. So inositol is a cyclitol which is derived from glucose. It is present widely in our body, produced by certain organs in our body like the liver, ovary, also present in a large number of food groups which are available. So essentially it's a non-essential molecule which does not need a replacement. That's probably the first important thing that we should all take in. If you're taking a look at the food sources from where you can get inositol, it's present in beans, it's also present in grains, also a few citrus fruits. So the daily recommended intake, there is maybe ranging from 1 gram to 4 gram, can be easily acquired from your diet if it's a good mix of grains and vegetables. There are close to 9 isomers, but the most common is myo-inositol, and the second most is D-chiro-inositol. And both of these are important because they seem to be involved in many functions related to metabolism and PCOS. Now, the primary focus of the fact is that inositol or myo-inositol gives rise to phosphatidylinositol, which is, as we all know, as this entire hall knows, an important secondary messenger in the cascade which follows after activation of the insulin receptor. So it is a secondary messenger which takes a key role in the metabolic actions of insulin at the muscle, the liver, adipose tissue. We all know that when there is insulin resistance, there is hyperinsulinemia. But we know that this insulin resistance is reserved to certain areas, these areas. If you take a look at ovaries, there is no insulin resistance which happens there per se. So when there is insulin resistance and hyperinsulinemia, what happens at the level of the ovary is different. Now, if you take a look at the twin cell for steroidogenesis in the ovary, ionositol plays a role both at the level of granulosa and at the level of the ovarian theca cells. At the level of granulosa cell, it has an important role in potentiating the oocyte maturation under the influence of FSH. And in the ovarian theca cells, we all know that both of these cells have insulin receptor. So the downstream messenger, which is inositol, does play a role in the theca cell for androgen production. There's a little bit of nuance here when it comes to androgen production. If you take a look at concentration of myo-inositol and D-chiro-inositol in the serum, it's roughly in the range of 40:1 in healthy women. If you take a look at the concentration in the follicular fluid, it's 100:1. And this 100:1 ensures that the quality of oocyte is at its best. The granulosa cell concentration of myo-inositol and D-chiro-inositol is 60:1 to make sure the follicles are making sure that the oocytes mature properly. And in the thecal cell, for optimal production of androgen, the ratio is said to be around 20:1. But what happens in PCOS? That's the question. Inositol, which is there in our body, either it is endogenously produced or derived from your diet, is eliminated through your urine, okay? That's point number one. From early on, we've had information to know that women with PCOS are excreting D-chiro-inositol a little more than their normal counterparts. So on this axis, you see urinary clearance of D-chiro-inositol, and you can see that women with PCOS are excreting more D-chiro-inositol. Now, why is that happening? This is a study which is looking at ovarian theca cells from women who have PCOS versus normal controls. And what this study went on to do was to look at the activity of the epimerase levels. And what they found here was that the epimerase activity was found to be upregulated in the ovarian theca cells of women with PCOS. What this essentially means is epimerase converts more myo-inositol to D-chiro-inositol, and that is getting excreted more in the urine, which roughly translates to the fact that the alteration in this ratio happens because of upregulation of epimerase, which is under the influence of insulin. So if I can recap what we just spoke about, in healthy individuals in the ovary, the aromatase enzyme is balanced by both myo-inositol and D-chiro-inositol to make sure there's an optimal production of estradiol from the testosterone which is produced. Now, in women with PCOS, because there's increased activity of insulin, the epimerase activity is upregulated, which means D-chiro-inositol levels increase, which now inhibits aromatase activity. The action of aromatase is to make sure that the androgen is converted to estradiol. That step is blocked, thereby there is hyperandrogenemia, okay? So much story, okay? So this kind of correlates with what is found in clinical practice, where in women with PCOS, the concentration of MI and D-chiro-inositol is altered significantly. The normal ratio in the follicular fluid is 100:1. In PCOS, it drops to 0.2:1, which means that there is follicular arrest, which means at the level of theca cells, there is hyperandrogenemia. So in management of PCOS, where we are really parched in terms of treatment options available, anything that shows up is like a huge ray of light. And that's exactly what's happening here. Everybody is extremely excited about myo-inositol because we've now in some way made a connection which kind of seems to be solving all our problems, okay? So the excitement stems from here, and the excitement is palpable, okay? The amount of information that is flooding the person who's sitting in your clinic, the demographic of 18 to 25 to 30 years is primarily through social media, and they already know all the drip on myo-inositol, okay? So we better up our game and know everything that there is to be known. So what about inositol and PCOS? What evidence do we have with respect to metabolic and endocrine function? I'm going to be showing data from 3 to 4 large meta-analyses which have tried to kind of use all the small RCTs with small group of people with follow-up lasting between 3 to 6 months and kind of make some sense which is of all the information which is available. One of the first is the most recent analysis published in 2025, which looked at metformin with inositol versus metformin alone. And the most important finding from this meta-analysis was that when you look at menstrual cycle regularization alone, if you combine the two, it seems to be doing slightly better than using just metformin. There was no significant change when it looked at hirsutism or acne, okay? And this is kind of a recurring theme. In another large meta-analysis published by Greff and al., they also noted that cycle normalization seems to be more in people who received myo-inositol as compared to people who received placebo or folic acid alone. So there seems to be some evidence there. But probably the most comprehensive meta-analysis about myo-inositol is the one done by Fitzen group, and this was done primarily to kind of synthesize information to provide information for the guidelines to be formulated, which were published in 2023. What is different about this guideline is that about 20 to 30% of people who make the panel for the guideline are people living with the condition. So this meta-analysis was done to kind of factor in the need for having information adequately updated before the guidelines are made. If you do not like looking at forest plots and just want sentence summary of what's going on, what the meta-analysis kind of found out was that there is some benefit for some metabolic measures and potential benefit for DCI for ovulation per se, but there's no strong evidence for us to know which combination works best or what could be the long-term effects of it. That's the one-line summary. But I'm going to dive in to a little bit of the details to see here that in this we are trying to look at myo-inositol versus folic acid. And you can see that there's no major difference when it comes to androgen levels, be it testosterone, androstenedione, some drop in fasting insulin levels, some drop in HOMA-IR, but no meaningful change when it comes to blood glucose levels. Okay, that's an important point to take away, with the understanding that no study has gone on longer than 6 months. No study has gone on longer than 6 months, and if you take a look at the number of people, no study has included more than 60 women in each arm. Okay, so this is very, very, very small groups of people from which we are trying to learn so much from. Now, metformin is a molecule that we are all excited about in PCOS for varying reasons. There are solid indications for its use for women in PCOS. How does myo-inositol compare to metformin? Because metformin itself has a little bit of resistance for women in this age group to get on it, right? And also it has GI side effects, which is not very acceptable. And like we all know, this demographic is a demographic which is very likely to go off all medications at the slightest hint of discomfort. So this next set of information is to try and see how myo-inositol compared with metformin, looking at, let us say, metabolic parameters, looking at also some of the endocrine parameters as well. And here you can see that when you're looking at myo-inositol versus metformin, when you're looking at fasting glucose, when you're looking at fasting insulin, when you're looking at total testosterone, and when you're also looking at SHBG level, it's right on the line. There are two ways of interpreting this. It's doing just as well as metformin, right? And that's something. It's not nothing. So maybe there is something that women who are taking myo-inositol are finding which is making their lives better when they come back and each time ask you if they can continue to be on it. So it's doing as well as metformin when you're looking at these parameters. And in some others, like for example, BMI, weight, and also waist circumference, again, it's doing just as well as metformin, okay? And when you're looking at this last one, where you're looking at GI side effects, the GI side effects are much lesser with myo-inositol use. But when you're looking at clinical pregnancy rates, if you're looking at waist-hip ratio and ovulation rates, again, it seems to be doing just as well as metformin, okay? So this is probably the most comprehensive meta-analysis with the information which is available as of today to suggest that there might be no meaningful change when it comes to clinical pregnancy rate, but it's doing just as well as metformin in metabolic parameters and endocrine parameters. Now, D-chiro-inositol is also a molecule which has been studied extensively, predominantly for ovulation rates and ovulation assisted reproductive techniques. This particular meta-analysis went on to say that supplementation with DCI seemed to improve ovulation rates. Now, a little bit of a dive down into fertility outcomes per se, because there is like a curve ahead in this road. This is one of the older meta-analysis which went on to show that when you used myo-inositol for fertility outcomes per se, it reduced the FSH dose required, lesser number of days of stimulation, greater number of oocytes, but no difference in clinical pregnancy rates. Okay, this was the older meta-analysis published in 2016, but the latest meta-analysis is this one published in 2025, which did show a 20% improvement in the odds of having a clinical pregnancy rate if you supplement with myo-inositol. But if you looked at live birth rate or delivery rates, there didn't seem to be any meaningful difference. Okay, so the fertility experts swear by it. So maybe the clinical pregnancy rates are relevant to them probably more than maybe live birth rates, but there is some signal here to suggest that it could be beneficial. Another meta-analysis which looks specifically at fertility outcomes in the assisted reproduction category is this one by Unanian, which also looked at close to 2,000 patients who also noticed that there was a slight improvement in clinical pregnancy rates with the use of myo-inositol or as compared to metformin. So there is some information here. But the thing about a curve in this road is that when D-chiro-inositol is given at varying doses, they noted that when the dose is high, it actually resulted in a fall in the quality of the oocytes and the number of the oocytes. And this is referred to as the DCI paradox. There's a school of people who believe that this is a real thing and a school of fertility specialists who believe that this is nothing at all. But there is publication here to suggest that maybe higher dose is poor. And one very often cited study is this. This study is important because it tested myo-inositol and D-chiro-inositol in varying ratios, okay? And what they found was that the highest odds of having ovulation was in the 40:1 ratio, and then ovulation rates dropped if you went higher than that, okay? That's everything that we need to know. So there seems to be a breaking bad point when it comes to D-chiro-inositol. With all of this information, what do the guidelines say? What is our take-home message, okay? So we go back to what the guidelines say, and it's important here to understand there's a heavy presence of people living with PCOS which is shaping up these guidelines. What they say about inositol is this, that inositol in any form can be considered for women with PCOS based on individual preference and values, noting that there is limited harm, potential for improvement in metabolic measures, yet with limited clinical benefits, including in ovulation, weight, or hirsutism. Metformin should be considered over inositol for hirsutism and central adiposity, noting that metformin has more GI side effects than inositol. We should also be aware that this is a molecule which can be produced in our body, can be freely availed if you eat a well-balanced meal, with the understanding that maybe it's not amenable or possible for all women, right? With also the understanding that the inositol supplementations which are available do cost quite a bit, and if it's something which you're going to recommend in the long run, could be quite a significant expense. So quickly summarizing, inositol is a secondary messenger of insulin. It mediates important metabolic functions of insulin. It also potentiates the effect of gonadotropins over the follicular and the granulosa and the theca cells in the ovary, mediating cycles and ovulation as well. The biological plausibility is present because in PCOS we've noted that the ratio of myo-inositol and D-chiro-inositol is significantly altered, and there is some evidence to suggest that supplementation could potentially affect metabolic, endocrine, as well as fertility outcomes in PCOS. We are still not clear as to the long-term safety of these molecules, their use, especially in the peri-pregnancy planning, the exposure of how this ratio could potentially affect quality of the oocyte, pregnancy, and also maybe long-term health of the fetus and mother. With all of this information, You could use it if your patient is asking for it. You could point them to the resources for them to collect information, but this is what is available. So is it really effective was my question. I think there is some smoke here, but can we see it clearly, or is it just a mirage? At this point, I think we should wait for more information. I'm not the one to proactively ask them to go on myo-inositol, but if they choose and ask, I tell them that they could be on it and to make sure that it doesn't contain any other additives to it, because the nutraceutical world is strange. You can add anything to it and get away with it because there are no regulatory processes making sure of their safety. So I asked them to choose something which is just inositol, and there are a few in the market. It's also an important point for us to understand that in medical science, healthcare professionals have been blinded because we think we know everything. And sometimes patients living with the condition have helped us understand management and treatment of conditions better, like for example, in adenoleukodystrophy, as in Lorenzo's oil was brought into focus by the mother of the child who was suffering with the condition. So there is something here and we should watch this space, but I've kind of summarized everything that's out there about this topic today. Thank you.
Thank you so much, Dr. Chitra. So we can take one or two questions, but before that, I have a question. If at all you decide to put in myo-inositol, which I'm not really sure we're going to do, but then if at all you do decide, is there a dosage? I mean, there are so many tablets available at various doses. What is the dose that is advocated?
So the most commonly used dosing is anywhere between 2 grams to 4 grams daily. So the available doses are 1 gram or 1,200 milligrams. So you can go up to 4 grams and not beyond that.
Sir.
So.
Chitra, are there dietary intervention studies comparing your quote-unquote healthy vis-a-vis non-healthy diet and its impact on serum myo-inositol and clinical outcomes?
So I did not review that. I will go back and do that, yeah.
Thank you.
Please.
Ma'am, I have two questions now. First question is, according to the trials done so far, which one is the stronger predictor of successful ovulation induction in a case of PCOS? Is it the BMI or metabolic profile of the patient or the ovarian morphology? And the last question is to Chitra ma'am. Ma'am, in your clinical practice, do you use myo-inositol as a sensitizer prior to initiate the actual induction therapy?
I'll take the second question because I don't know who the first question was for. No, I do not actively write out prescriptions for myo-inositol, but I check if they are on it and I make sure that it does not contain other additives where I don't know what those molecules are standing for, and tell them that we have information for myo-inositol alone and I don't have a specific ratio of myo and D which they should take. The first question was for you, Arundhati?
Was for the first speaker, I believe, because he wanted to ask the first speaker.
Oh, okay.
Yes. Let me repeat the question. According to the trials done so far, which one is the stronger predictor of successful ovulation induction in PCOS? Is it the BMI or metabolic profile of the patient or the ovarian morphology?
Ma'am, you could take the mic.
I think that's what I wanted to highlight by saying that we really need to categorize the patients, and there are no predictors. But as Dr. Dokras explained to us, that definitely weight loss, because they'll be spontaneous, but there's no correlation that BMI or PCO morphology. PCO morphology doesn't tell us anything other than that this patient is anovulatory. So I don't have a better answer than that. No.
So it's more of a comment, Dr. Chitra. First of all, congratulations. It was a very well-researched talk and it was very simple to understand. So I'm checking if I'm understanding correctly. That as endocrinologists, our default setting is if somebody says they're taking myo-inositol, either because they're taking it on their own or the gynecologist has recommended, we are not very positive about it. We tend to be more negative about it, and we seem to randomly comment, it's what I've done in my clinic in the past, that it doesn't work, there is no evidence. But if I'm understanding correctly, at least as of now, there's no evidence for harm. It could possibly be as good as metformin in some aspects, maybe better tolerated than metformin. And if we could find a formulation which is reasonably, like you said, hits about 40:1, then we would not be doing any harm.
Yes.
At least as of now.
Yeah. Previously, I would say, no, stop it, it's of no use.
Exactly.
But now I'm saying if it's working for you, it's working for you. Because many women do report that their cycles are getting regularized with it. Yes. Yeah.
So many of the patients who I have seen, they've been started by the gynecologist on this and they do report much, much better cycles.
Also, many nutritionists start because most of the women with PCOS are in touch with a nutritionist. So the nutritionists do encourage them to go on Myo-inositol. So many of them are on it on recommendation by the dietitian.
Okay. So maybe we just need to kind of change our perspective a little bit. Thank you so much.
Thank you.
Thank you so much, Dr. Chitra. Thank you.
Done.
Oh, do you have another question? No. Okay. Oh, this is the last one.
Ma'am, you were talking about the dosage, that 2 to 4 grams. But ma'am, I'm a gynecologist. So our world is full of this combination with 550 Myo-inositol. And even if we give it 2 times, it is 1,100. Is this okay? Or is it too low? It doesn't make any sense.
No, ma'am. The mean Myo-inositol which has been studied ranges from 1 gram to 4 grams. So I think 1 gram is your reaching dose which has been studied. Yeah.
Okay. Thank you.
Thank you, Dr. Chitra. So we'll go on to the next topic, and that will be delivered by Dr. Jayashree Swain. And that's also a very interesting topic where we'll be talking about the timing hypothesis, the very important aspect of when to place the estrogen in terms of benefit for cardiovascular benefit and postmenopausal hormonal therapy. So Dr. Jayashree Swain.
Thank you, Chairperson, for this nice word of introduction. So my topic is timing hypothesis and postmenopausal hormonal therapy. So as we know, menopause is a permanent cessation of menstrual cycle and diagnosed retrospectively after 12 months of amenorrhea, and is due to this depletion of the ovarian follicles and is associated with the gonadal hormone, decrease in the gonadal hormone. HRT particularly refers to the replacement of the estrogen with or without progesterone for the management of the menopausal syndrome and symptoms particularly. So if you look to this particularly, the stages of the reproductive cycles, it is a reproductive phase followed by the menopausal transition, followed by the postmenopausal. And again in menopausal transitions, you may divide it at early and late. And in postmenopausal period, you may divide also early and late, which is depend on these symptoms, presentation of these symptoms and hormonal changes. And early menopause may be 2 years plus 3 to 6 years, followed by the late menopause. And menopausal transition similarly of a variable period and 1 to 3 years. All things are depend on these presentations of these symptoms and hormonal changes. If you look to this, particularly this beautiful graph, this lower panel, it is decrease after menopause, there is decrease of the estradiol, inhibin B, followed by the increase of the gonadotropins, particularly FSH and LH. This is in relation to the time taken for the last periods, which was in years. And menopausal age, if you look, it varies from the geographical area and racial variation also. Particularly in Asia, it is 48.8 years. And if you look to these Indians, it is 46.6 years in the Indian. And coming to the menopausal syndrome, these symptoms are varies. It is from the central nervous system to that of the bone and muscles. You may have these vasomotor symptoms, sleep deprivations, depression and anxiety, and cognitive changes, and sexual dysfunction, and urogenital symptom, lots of urogenital symptoms ranging from that of the vaginal dryness to that of the frequent urinary tract infection, and skin changes may be thinning of the skin, decrease of the hair and wrinkling, to that of the weight gain and changes of metabolic changes of the body contour. And along with that, joint pain and sarcopenia may be the manifestations of the menopause and menopausal syndrome. So the manifestation of the estrogen deficiency varies from perimenopause to that of the advanced age, it depends on the estrogen levels. In early menopause, early period, it may be the hot flush, sweating, insomnia, menstrual irregularity, and psychological symptoms. If you look to this, followed by that, there is vaginal atrophy, dyspareunia, skin atrophy, and urogenital stress incontinency. After that, in latter phase, there may be osteoporosis, atherosclerosis, coronary heart disease, cardiovascular disease, and dementia and Alzheimer's disease. But during all this period, there is reduced quality of the life due to the depletion of the estrogen. So, if you look to the prescriptions of the estrogens and trials regarding this hormonal replacement therapy, it is early, there is rise and fall of the estrogens, fall of the prescriptions of the estrogens. And in 1942, there is conjugated equine estrogen first introduced. There is rise of these prescriptions. Followed by that, in 75, there is decrease in the endometrial cancer risk is recognized. So after that, there is decrease of these prescriptions. And in 80, there is combined estrogen progesterone is introduced, and followed by again there is a rise. And in 90, there is publications of the North Health study and publications of the postmenopausal estrogen progesterone intervention trial, and there is a great rise of the prescriptions of the hormonal HRT. And followed by that, in 1980, there is HERS trials, there is heart estrogen progesterone's replacement study is published. And after that, these famous WHI Health, Women Health Initiative studies, trials are published, and you may look to this graph. There is particularly rise and fall of these prescriptions after these publications of this result. So what is our previous knowledge regarding this hormone replacement therapy? That is feminine forever. It is accepted as is appropriate and safe, and for the treatment of the menopausal syndromes and for the chronic disease prevention, including the cardiovascular disease prevention and mortality. So it is feminine forever, followed by the healthy forever is the notion earlier. And these are for the data from these are the from the observational study. After that, this randomized study came into this field, where this HRT show no beneficial effect, and it is the horse trials in which there is early harm was noticed in the horse trial. There is increased events occurring in the first 1 and 2 years, which has been seen in the horse trial. So feminine forever, followed by the health forever, followed by the no beneficial effect on the HRT, and followed by the harm noticed in the horse trials. But this, if you look to the WHI, the result of the WHI is something different. So after the publication of the WHI, there is a decreased prescriptions of the HRT of 80%. So what is that in the WHI? There is increased rate of the invasive breast carcinoma in the tune of the 24%. Then overall incidence of the coronary heart disease increased by 24% over the period of the 5-year use, and with the most substantial elevation of the risks within the first year, which is increased into or in the tune of 81%. Stroke incidence increased in both arm, both estrogen and estrogen progesterone combinations arm in the tune of 31 to 39%. Venous thromboembolism, whether it is the pulmonary thromboembolisms or deep vein thromboembolism, it increases twofold. But surprisingly, these women who started this therapy within 10 years of this menopause, there is a risk reduction of this coronary arterial disease, coronary heart disease by the 10%. So, in spite of this abundant data demonstrating the safety of the menopausal hormonal therapy in the younger post-menopausal women, the prescriptions rate has remained extremely low. Now it is the estrogen prescriptions is only 3 to 4% of the in the perimenopause and post-menopausal women, which was previously 25 to 30%. Then what is the main thing behind this? It is the risks and this benefit of this hormonal replacement therapy. Then what is that? Here the concepts of the timing hypothesis coming into the play. So timing hypothesis, what do we mean by that? This hypothesis suggests this cardiovascular, particularly the possibly the cognitive and the bone effect of the menopausal hormonal therapy depend on the timing of initiations relative to the menopause. Early initiations may have this beneficial effect and late initiations may increase the risks. So what is the biological basis of the timing hypothesis? If you are prescribing hormonal replacement therapy less than 10 years of this menopause or less than 60 years of this age, there may be the beneficial effect. It activates the enzymes which is responsible for the nitric acid synthesis, reduced inflammation, inhibits the LDL oxidations, it protects vasculatures and neurons. If it is late, then there is destabilization of the plaque, worsens neuronal and neuronal degeneration. So you may not get that much of the benefit. This is the biological basis of the timing hypothesis. So support of that timing hypothesis, we have some trials, that is the subgroup analysis of the WHI, KEEPS trials and allied trials. If you look to the subgroup analysis of the WHOI, here they have taken 50 women in the age group of this 50 to 59 years and durations less than 10 years, and here they are getting neutral effect and favorable cardiovascular outcomes. Median duration of the follow-up was 5 years, and they have prescribed here conjugated estrogens and the medroxyprogesterone acetate. If you look to the KEEP trials, which is the estrogen Krugnos early estrogen prevention studies, here oral estrogens or the transdermal estrogens plus progesterones they have given and followed for these 5 years, and early those women who have age group of the 42 to 50 years are included in this study. What is the result? Then key result of this study, there is favorable effect on the vasomotor symptoms and also some lipid metabolisms, lipid parameters are improved, and also there is no effect on the carotid intima medial thickness progression. That is also one in other way a favorable effect. And if you look to the allied study, which is early versus late intervention trials with the estradiol, and here median follow-up is 5 years and the study populations are less than 4 years versus these more than 10 years, and the key result of this allied study, estradiol shows progressions, slowed the progressions of the carotid medial intimal thickness only if it started less than 6 years of the duration, which has been not seen with the more than 10 years of the duration. So this is the key study which support the timing hypothesis. So it is the KEEPS trials, carotid media intimal thickness, and they have the secondary outcome of the coronary artery calcifications, which is having favorable effect after this from the result of the KEEPS trial. Next, that is early versus late allied trials, and oral estrogens have beneficial effect on the or slow progressions of the subclinical atherosclerosis is there. So timing hypothesis, early initiations, there may be the benefit of relief of symptoms, bone health, possibly cardiovascular protections, late initiation, risks are there. Risks may be the coronary events, stroke, venous thromboembolisms and dementia. So coming to some things basic, that is HRT prescribed in postmenopausal women. As we know, all indications, most of common indication is vasomotor symptoms, around 80% of the cases, and followed by the genitourinary symptoms, mood depressions, and hypoactive sexual disorders, and sleep, joint muscles, and ache. We are rarely prescribing. We all know the contraindications, abnormal vaginal bleedings, and history of breast cancers, endometrial cancer, ovarian cancer, or active disease of the coronary artery disease, venous thromboembolism, strokes, and liver disease are these contraindication for the hormonal therapy. Again, then what is the recommendations for the vasomotor symptoms? Endocrine Society clinical practice recommendations, if women less than 60, less than 10 years of the past menopause and uterus is intact, you may go for the estrogen progesterone. If without uterus, only estrogen therapy is indicated. For this, we have estrogen preparation, 17 beta estradiol, conjugated equine estrogen, synthetic equine estrogen, esterified estrogens, ethinyl estradiol in various formulations like patch, oral preparation, topical and vaginal preparation in the different doses are available with us. We have also the progesterone preparations like medroxyprogesterone estate, micronized progesterones, norethiosterones, levonorgestrols or dihydrogesterone available in these various formulations, various preparations and various doses are available. Similarly, for genitourinary symptoms, we have the topical preparations of the estrogen in the form of the cream, ring and or the tablet form are available. So, if you look to the Cochrane review regarding the HRT on the vasomotor symptoms, there is a substantial benefit. HRT decreases the vasomotor symptoms frequency by 75%, so also severity, and all type of estrogen, whether it is conjugated estrogens, 17 beta estradiol or transdermal estrogens, all are effective in decrease the vasomotor symptoms. This is the result from the Cochrane review. If you, next coming to the HRT and cardiovascular risks. And this is the review, Cochrane review, where the women, they have taken women less than 16 years or less than 10 years of the post-menopause and follow for this period of the 5 years hormonal therapy. Here what is the result then? The all cause of the death, the coronary heart disease, which includes the fatal myocardial infarctions and the death from the coronary events, is decreased if you are starting the hormone therapy early, that means less than 60 years, and the hormone 10 years within the 10 years of the menopause. And after 10 years of the menopause, what happened? That beneficial effect may not be there. Regarding the all cause of the death and coronary event, it may be the flat, this curve may be the flat or relative risk is not so statistically significant. That is not seen after 10 years of the menopause. So whether it is the, if you look to the systemic review and meta-analysis, whether it is the randomized trial or placebo control or the observational study, early initiations of the estrogen therapy of HRT have beneficial effect on the cardiovascular outcomes. Next, coming to that risks regarding the venous thromboembolisms, here transdermal estrogen versus the oral estrogen preparations. If you look to the study, all of recently published meta-analysis, this transdermal estrogen preparation, transdermal estrogen and progesterone preparation has beneficial effect, or the risks of the venous thromboembolism is less when compared with that of the oral preparations. So, if you look to these preparations regarding these venous thromboembolisms, whether transdermal estradiol or combined preparation, or transdermal estradiol in the dose of the more than 50 or the less than 50, there is beneficial effect or risks of this venous thromboembolism is the less, which is seen from the meta-analysis. So, what about the breast cancer? And if you look to these endocrine society clinical practice guidelines, before prescribing this hormonal therapy, we should go for the international breast interventions study risk classifications. In intermediate and high groups, you may defer this hormonal therapy and you may go for the non-hormonal therapy if vasomotor symptoms is very bothersome. And regarding some aspects of this mood and cognitions, it is this key cognition and affective study in which these conjugated equine estrogens or these transdermal estrogens have some beneficial effect of the mood, not all these parameters of the mood. Regarding particular depressions and the dejections parameters, there is some improvement in these early initiations, that means age less than 60 years. The average durations mean age is 52.6 years here. And again, these parameters of this depressive parameter, it has been seen from the different study. It is seen as early as 12 weeks, and it is persist after in the washout period, where these postmenopausal periods, in postmenopausal syndrome, these depressive, these postmenopausal symptoms, they persist after the washout period. So it is not there. but there is favorable effect on the depressions. Regarding that of the effect on the menopausal hormonal therapy during the duration and formulation. If you are starting early, here is one study, the verbal memory is improved, early estrogen therapy which is not there in this late or that is late estrogen progesterone preparation. So it is something favorable if you are starting early. There you may be got some aspects of the beneficial aspects in the mood and depressive disorders and cognitions. So regarding the combination therapy, if it is regarding this selective estrogen receptor modulator, you can combine this with the estrogens if the bothersome vasomotor symptoms are there. Endocrine Society clinical practice guidelines they recommended, and this is the some preparations, combined preparation in which we are getting so much of the benefit regarding the decrease of the frequency of the vasomotor symptoms and decrease of the hot flush. So regarding the non-hormonals, we have the tubolones, and it is both estrogenic, androgenics and progesterone activities are there, and it is very much, it reduces the frequency and severity of the vasomotor symptoms. So though the unscheduled vaginal bleeding is less common than the HRT, but the risks of the breast cancers and the risks of the strokes is there, which has been seen from the Liberate trial and the LIP trial. And the Endocrine Society clinical practice guidelines, they are against the recommendations of adding tibolone to that of the hormonal preparations. So to summarize my presentations, HRT is most effective for vasomotor symptoms in 75 to 85% of the patient. Transdermal estrogens have the best safety profiles, and timing hypothesis has a significant role on prescribing this hormonal therapy for the beneficial effect. It has this beneficial effect on the cardiovasculars, cognitions and the mood. And regarding this HRT in cognition, though there is no much beneficial effect in every aspect of the cognition, but the mood and depressions has some beneficial effect. 17 beta estradiols and micronized progesterone and dihydrogesterone have least risks of these venous thromboembolisms and these breast cancers. When contraindications are there, you may go for the non-hormonal therapy, but hormonal therapy we should look to the timing hypothesis. Less than 60 years, less than 10 years of the menopause, and that you can prescribe this hormone, you may get this is some of this benefit which I have discussed. So thank you for your patience hearing.
Thank you, Dr. Jayashree. We can take one or two questions. I have a question. When you're talking about the timing hypothesis and the window of opportunity, less than 60 years, say for a patient for a lady who's had PCO or who has hypertension, would the timing hypothesis remain the same? I mean, they have been vascularly unhealthy throughout.
No, it is the observations from the large landmark trials. So it is the retrospectively we have calculated those age who are 50 to 59 years, and these are 10 years, the durations of less than 10 years post-menopause, they are getting some benefit and the cardiovascular risks benefits.
No,
Risks.
yes.
So it is favoring. Cardiovascular risks, they have favorable benefit on this lipid parameter, increase in the HDL, decrease in the LDLs, and insulin resistance. There is some improvement in the insulin resistance, and carotid intimal medial thickness progression is less if you start this therapy in that period.
So does it apply across the spectrum for all women, or would women who've had...
It's the observations from these trials. These trials are not designed to see that things. We are getting this a harm effect. So after that, there is subgroup analysis which we have noticed that this is this timing period. If you are prescribing in that period, you may get this benefit.
I think there have been some studies which have looked into this cohort with PCO or who've been metabolically unhealthy, and they have not really extended the timing to that.
I think that the future study will study.
Right, thank you. So do we have any questions?
Madam, can you highlight the non-hormonal therapy in this case? Non-hormonal therapy.
Non-hormonal therapy, regarding that I have given SARM, selective estrogen receptor therapy. My topic is a little bit beyond that, so that's why I have not concentrated much in that things. My topic is timing hypothesis. Means at which time you are going to prescribe this hormone, then you will get this benefit. Why there is decrease of these prescriptions after the WHI?
I think if there are no more any further questions. So one thing is, I feel they have not looked into a subgroup or like they did not exclude either. No, those people who had cardiovascular risk, they did not exclude. So short of data, I think we should assume
In
that
first
others also
study, they have taken
benefit.
every group.
So,
every
I
group
mean,
of
there
this
have been smaller studies which have looked, because supposing it's a 50-year-old, but she has diabetes, she's got hypertension, she's had PCO, she's been metabolically unhealthy for a considerable period of time. She would not be the same as another 50-year-old who doesn't have all of this. So these are separate cohorts. I do not think we can put everybody into the same frame.
Yeah, but the thing is, like, they have not been excluded. High risk people have not been excluded. Short of data, we should probably assume that they also derive benefit, whether more or less.
Thank you.
So
Just
thank you, Dr.
having ma'am, just having one query. So many cases we see the patient of surgical menopause. So though these are in early age, they got surgery for hysterectomy or total oophorectomy. So in that cases, the timing hypothesis will fit like that.
Yeah. Timing, if there is troublesome vasomotor symptoms, then only you will go. You know these indications. That's why I have put one slides of these indications. Come on, what are the indications you are going to prescribe the HRT? And you should know these contraindications simultaneously. So this is the common things. After that, in surgical, if surgical menopause, you are if vasomotor symptoms is bothersome or genitourinary symptoms is bothersome, in that case you may prescribe. And if the lady is in that age group.
So age would be a deciding factor there.
Okay, thank you.
Thank you.
So I think we have no more questions. Thank you, Dr. Jayashree. Thank you.
Thank you.
Thank you. Now we are moving on to our last academic session for the day. It is on idiopathic hypogonadotropic hypogonadism, spectrum, and reversal debate. For this, I would like to invite on stage our chairpersons, Dr. Vikram Singh Chauhan and Dr. Shayantan Rai.
So good afternoon. So we have two consecutive talks on congenital isolated hypogonadotropic hypogonadism. For the first talk, I would like to invite Dr. Nishant Raizada.
Thank you, respected chairpersons. So the topic that I'm going to speak upon is the clinical spectrum of idiopathic hypogonadotropic hypogonadism. This disease has also been referred to as isolated hypogonadotropic hypogonadism or congenital hypogonadotropic hypogonadism. But as you know, it reflects a form of congenital hypogonadism in the setting of otherwise normal anterior pituitary function. So going to the epidemiology, initially one historical study reported that this is as common as 1 in 4,000 males, but subsequently we have data from Finland which suggests that actually the prevalence is 1 in 48,000, and it is of course much more common in males than females, with the male to female predominance being 4 to 5:1. Moving on to the presentation, in infancy the two key presentations of IHH are micropenis and cryptorchidism. So let's begin with micropenis. So micropenis refers to a penis which is structurally normal but abnormally small in size. The definition is stretched penile length 2.5 STs below the mean for that age and sexual stage. As per the broad consensus, this cutoff is around 2 centimeters at birth and less than 4 centimeters after 5 years of age. We do have some normative data from India also. This is a study by Dr. Sriram Mahadevan and his team. They looked at 346 neonates and the mean SPL in these neonates was 2.83 centimeters, and the ST was 0.49. So the minus 2.5 ST here would come around 1.7 centimeters, so which is in line with the international accepted cutoffs also. Then coming on to cryptorchidism. Cryptorchidism is apparently quite common. It can be seen in as many as 1/3 of the cases of IHH. Out of these 1/3 cases, half would be having unilateral cryptorchidism, whereas other half would be having bilateral cryptorchidism. Cryptorchidism, you know, apart from other things, is associated with decreased response to gonadotropins at adolescence and also correlates with poor fertility outcomes. What is the mechanism of cryptorchidism in IHH? The inguinoscrotal phase of testicular descent depends upon the androgens. There is an inadequate gubernacular migration and inguinoscrotal descent. These children also do not have a mini puberty, and mini puberty is the time at which in many cases the testes descend. And also the insulin-like peptide 3 or INSL3, it is secreted by the fetal Leydig cells, and it is crucial for the transabdominal phase of descent. And it is known that LH deficiency may also lower the expression of INSL3. Now this slide is important. If you have severe genital abnormalities, such as hypospadias or any other form of abnormal genitalia, so that is abnormal fusion, those are very critical pointers which take the diagnosis away from IHH or CHH. You should think of DSDs in that setting, because they indicate that there is a defect in the either HCG-mediated secretion of androgen or in the action of androgen. So a diagnosis of IHH should not be made if you have hypospadias or any other associated more severe genital abnormalities. At the same time, if you have a female neonate, there will be no clinical signs or symptoms at the time of the birth. Now moving on to the next stage, that is adolescence. Adolescence, the typical presentation is delayed puberty, which is of course defined as absence of testicular development in the boys by the age of 14 and absence of breast development in girls by the age of 13. The patient may present with absent or no virilization, low libido and lack of sexual function. For a majority of patients, there is no puberty at all, but less commonly they could have arrested puberty. There is some progression of puberty occurred in the beginning, but it did not go the full way. One important thing to remember is that the chief differential diagnosis of IHH in the adolescent period is CDGP. Now there is an entire talk on this specific topic in an adjoining hall, so I will not spend a lot of time. But I'll say that although there are clinical and biochemical differences between IHH and CDGP, still there is significant overlap. And therefore, making a diagnosis may be difficult, especially at a single point of time. But still we must remember that CDGP is much more common than IHH, and therefore due workup should be done before we label the patient as IHH. Now one clinical manifestation that is seen in IHH is unicoidal body proportions. So I'll first draw your attention to this famous drawing. This is the Vitruvian Man. This was made by Leonardo da Vinci sometime in the 14th century. So Leonardo da Vinci figured out that the human body is symmetrical, and if you spread out your arms and stand straight, you can draw a square around the edges of the body, which effectively means that arm span is equal to height for most normal people. In IHH, because the fusion of epiphysis does not occur, because there is a deficiency of the sex hormones, the bones continue to grow. So you'll get a person who is tall. Now, if a person's lower limb and the upper limb both increase in height by 10 centimeters, then the gain in height is only 10 centimeters because the legs are in parallel. But when you stretch out your arms, each arm is growing 10 centimeters, so overall you'll gain 20 centimeters. So effectively you'll have 20 centimeter increase in the arm span, but only 10 centimeter increase in the height. So therefore, an increase in arm span more than height, commonly said more than 10 centimeter, is a marker of unicoidal body proportions. So unicoidal body proportions refer to a person who is abnormally tall and who's got an arm span more than the height. In adults, the manifestations of IHH could be erectile dysfunction, low libido. They can have infertility. Some patients may present very late with osteoporosis. They may also have depression or anemia. Females can have secondary amenorrhea, infertility, and also osteoporosis. Now, typically patients should get diagnosed before adulthood, but sometimes they can present late. The reason for this could be either they did not find opportunity to make the diagnosis. In our country, we may not have enough experts to identify the disease in time. And sometimes patients themselves may be reluctant to seek medical attention for socioeconomic reasons. Now we come to the key clinical manifestation which helps in differentiating this into anosmic and non-anosmic variants, and that is anosmia. So as we know that the GnRH precursor neurons, they arise from the olfactory placode, and from there they travel along the olfactory axons to the through the cribriform plate into the olfactory bulb, and from there they migrate to the hypothalamus, and then they begin the secretion of GnRH when the time comes. Now, there are some genes which are involved in the development and migration of these neurons, genes like CAL1, FGFR1, FGF8, and affectations of these genes will cause an anosmic version of IHH, which is also called Kalman syndrome. On the contrary, genes such as LEP1, KIS1R, and FGFR1 may be involved in homeostasis and GnRH secretion, and if these are affected, you will get a normosmic variation of IHH. Now, to identify anosmia, typically what is recommended is University of Pennsylvania Smell Identification Test, or UPSIT. This classical test was developed for the North American population, and this had 4 booklets. Each booklet has got 10 pages. Every page there is a scratch card sort of a thing. You scratch it and smell comes out. You have to smell it and then you have to answer the question. So there are 40 questions in the original test. But later found out that this test is not very familiar to the people in other countries, so they came up with a culturally modified version, which is a brief SIT, which has got 12 questions. During the COVID time, in fact, there was more interest in identifying anosmia, and some even simpler tests such as the nasal 7 questionnaire, nasal 3 questionnaires, in which we have got only 7 or 3 smells, commonly available items at home, that can also be used to quantify the anosmia. Now, this is the largest series which looks at the anosmia in patients with IHH. This was published in JCM, and they studied 286 patients with IHH, 201 males and 85 females. And they also looked at 2,000 healthy controls. So in this, you can see in the panel C below, they found that out of the IHH patients, nearly 30% had anosmia, another 35-40% had hyposmia, and the remaining 40% had normal nasal function of smell. Whereas in the controls, which is the D panel, the prevalence of anosmia was less than 5%, and maybe around 7-8% had hyposmia. Another thing which they identified is that self-reported olfactory assessment can underestimate the actual deficit. So they looked at the people who claimed that either their smell was normal or it was slightly impaired, and even out of those people, 20% had absolute anosmia and 40% hyposmia. So even people who are reporting that I don't have any problem with my smell, even when objectively tested, they could also be having some evidence of anosmia or hyposmia. And therefore, when we are encountering a patient, we should not rely only on history taking to make the diagnosis. They also found that the presence of anosmia correlates very well with the structural abnormalities in the olfactory structures. Among the people who had such abnormalities in the olfactory bulb area, only 1 had normosmia, whereas among the people who had absolutely normal olfactory bulbs, none had anosmia. Bimanual synkinesia is also a very key clinical manifestation seen in some patients. It is also called mirror movement. This seems to be specific to the Kalman syndrome X-linked variety, that is the Cal1 gene mutation. It can also be seen, however, in other acquired conditions like stroke or Parkinsonism. But when present in the context of isolated hypogonadotropic hypogonadism, it can help you make a diagnosis. So this is a publication from JIPMER and by Dr. Swadesh Kumar Kamalanathan and his team, and they've reported this bimanual synkinesia. There is also a video, I hope it plays. Yes, so this is a video demonstrating the bimanual synkinesia. Now, deafness is another manifestation that has been observed in IHH, and recently a study showed that deafness appears to correlate with SOX10 mutations. So they looked at 13 people who had IHH and also had deafness. Out of them, 6 of these cases had SOX10 mutation. Dental abnormalities have also been reported with IHH, and in one particular series, it was shown that these are more common with FGFR1 mutations. The abnormalities seen included microdontia, screwdriver-shaped mandibular incisors, and thin molar roots. And there is a pattern of dental agenesis in which the lateral mandibular incisor is the most commonly involved, followed by the second premolars, followed by the lateral maxillary incisors. So it's the incisors and premolars which are often agenetic. Then coming to cleft lip and palate. Cleft lip and palate are again seen more common with FGFR1 mutation. They can be seen overall in 5 to 7% of cases. They can have increased mandibular angulation and inclination, and extreme retrographism can also be seen. And some patients may even have abnormalities of the sphenoid bone. Pigmentation defects are also common. They can be in the form of hyperpigmented patches or albinism-like features, seen commonly with FGFR1 and PROC2 variants. They can have cutaneous pigmentation defects such as generalized or patchy hyperpigmentation. They can also have hair pigmentation such as graying of hair. They can also have hyperpigmentation of the retina and the iris. Now this is one of the systematic review which shows some of the common developmental abnormalities. So bimanual synkinesia, renal anomalies, orofacial defects and eye movements. And all of them seem to be much more common in the anosmic variants rather than the normosmic variants. This is another systematic review in which the cryptorchidism and micropenis etc. have been described, and you can see cryptorchidism was seen in this series in 28%, whereas micropenis was in 21%, and microorchidism in 4%. And then they have given the percentages of people with both the defects together, all the combinations, cryptorchidism with micropenis, cryptorchidism with microorchidism, and so on. Now we have a lot of Indian data, but all of that is from one center, that is KEM Mumbai. So they have done a lot of work in this field, and they have got a large series of around 135 patients with IHH. And this is one of their initial publications in Clinical Endocrinology 2016. So out of these patients, majority of them had an anosmic variant, that is the Kalman syndrome, and a smaller percentage had the normosmic variant. And they've shown the severe phenotype. There is a severe phenotype which can be seen in more commonly in the Kalman syndrome. I hope the slide is visible. It's a little small in print. So what they've shown is that the severe phenotype was 46% in the normosmic variant, but it is 81% in the Kalman syndrome variant. And the microphallus and cryptorchidism were reported in around 84% of the cases were in the Kalman syndrome group. The other manifestations were synkinesia, renal agenesis, dental agenesis, and digital anomalies, all reported in both the, but more commonly in the Kalman syndrome group. They have also reported a genetic spectrum of Kalman syndrome, and they have shown the clinical features of the severe phenotype and the partial phenotype. The severe phenotype here was the patients who had absolute absence of puberty. The testicular volume was less than 4 ml, or there was no breast development in the females. And they have found that the male to female ratio, it is is higher in the severe phenotype. It is relatively lesser in the partial phenotype in the case of Kalman syndrome. And cryptorchidism in their series was only in 6 cases, which is around 13%, which is slightly less than what is reported internationally, which is around 30%. And there was significant difference between the gonadal hormones, that is LH-FSH, in the severe and the partial phenotype, which is expected. Molecular diagnosis was made in 20% of cases of the severe phenotype, but only 4% cases in the partial phenotype. These are the common genes which they found. The most common gene in this series was ANOS1, followed by FGFR1, and then PROCR2, PROC2, and GnRH were 1 cases each. And there were 3 cases which double genetic abnormalities, such as ANOS1 with PROCR2, FGFR1 with SOX10, and FGFR1 with FGF8. They've also shown their experience with normosmic IHH, and out here you can see that the male to female ratio is a little bit lesser. It's around 2:1, and again it is maintained in the severe phenotype and partial phenotype, and the familial cases were more in the severe phenotype. Again, cryptorchidism was seen in around 6% of cases. Hearing loss was seen in 2 cases only, and again the LH-FSH were lower in the severe phenotype group. Molecular diagnosis could be made in 44% of cases in the severe phenotype, and the genes reported include GnRH gene in 11 cases, FGFR1 in 5 cases, KIS1R in 3 cases, and GnRH1 in 2 cases. TACR3 and CHD7 were seen in 2 and 1 cases respectively. They have also reported 2 rare variants of the GnRH1 in the CHH. So this is sort of a summary table. We've got an anosmic and a normosmic variant. Pathogenesis we know already. There is a defective migration in an anosmic variation, whereas there is a defect in GnRH secretion in the normosmic variant. The genes involved include ANOS1 and FGFR1 predominantly in the IHH, anosmic IHH, where in the normosmic variant we have GnRHR and KIS1 genes. Olfaction, of course, would be affected in the anosmic version. Extragonadal features are much more common in the anosmic version as compared to the normosmic version. Epidemiologically, the anosmic version is more common, almost 60%, whereas the normosmic version is around 40%. And in terms of inheritance, anosmic variant can be X-linked or autosomal dominant or autosomal recessive, whereas autosomal recessive is more common in the normosmic variants. MRI abnormalities would be seen more in the anosmic, whereas it will be normal in the normosmic. Delayed puberty with anosmia would be the presentation in case of anosmia in anosmic version along with syndromic features, whereas in the normosmic version, which is a delayed puberty with intact smell, and this is the variant which is more likely to be confused with CDGB. This is a table which is showing a summary of the clinical manifestations. across the fetal and the peripubertal and the adult period. So that is all about my talk. Thank you.
Yeah, thank you for your nice talk, Dr. Razada. So, any questions from the floor on this talk?
Dr. Nishant, I had a small question. Just a very small thing. World literature generally, what is described in textbooks is that Coleman's, you'll have 20% cases where the olfactory bulbs are normal. Is there anything in the studies that you've reviewed about Indian data being any different?
Indian data?
Yeah.
No, at least whatever I looked at, I didn't find any Indian data which talks about what percentage of Kalman are having MRI abnormalities. The largest series that we have is, of course, I think KEM only. But I went to the publication, but didn't see specifically. I didn't look for this topic also. I'll accept, but I don't remember reading anything to that effect.
So, one question to you, that's what is your comment on when there is biochemical and pubertal phenotype discordance and concordance?
With respect to?
With respect to IHH.
Okay. So clinically the main difficulty comes when the adolescent patient presents to us and the patient is having low gonadotropins and there is absence of puberty. So this is the area when we struggle the most, and that is the main debate whether it is CDGP or it is IHH. The key problem that we face is CDGP is much more common, but still it is a diagnosis of exclusion. So we have to exclude IHH only, then we can say it is CDGP. And the best way to go through is generally to wait for some time and see what happens. That is the easiest way to do it. But if you want to make a diagnosis right then it becomes a little challenging. Now, if you find any clinical abnormalities such as anosmia, or you can find any other genetic abnormalities which is described in my talk, then you are more likely dealing with IHH. And then you can think of confirming it biochemically, but with one of the more newer tests, which is inhibin B or a stimulated inhibin B assay. Although the conventional GnRH stimulation test has got a significant overlap and very difficult to make a diagnosis clear cut on the basis of that test alone. So that is, I think, the way to go about it. Yeah.
Thank you. Thank you for this.
So we'll move on to the next speaker. I invite Dr. Santosh Kumar Singh to please step on stage. Practicing endocrinologist in Patna, 54 publications to his name, currently president of the Bihar chapter of ESI and has been past president of the RSSDI. Over to you, sir.
Honorable chairpersons, respected seniors, dear friends, at the outset, my sincere thanks to team ASCVD 25 and a big congratulations for this grand successful conference. This conference will be special for me. One, because I am the last speaker for this conference. Second one, my respected teacher, Professor J.K. Agarwal, was given the Lifestyle Achievement Award. And thirdly, very interestingly, my younger brothers, one is the president, the other is president-elect. So Kaushik and Sujay. So to start with the topic, reversal of IHH, again a positive thing to end our conference. So this is for you all, a very quick one. Reversibility in IHH reported 5%, 10 to 20, 18, all of the above. Any guess? 3, 4 questions for you. I couldn't hear anything. Anything? 10 to 20, okay. Reversibility in IHH, this is in the older text, you will find mention of KS1, 2, and this is hypogonadotropic hypogonadism. If we go into the present day data, this is termed as hypogonadotropic hypogonadism, type 1, type 2, type 7, and whatsoever. So in this one, reversibility in IHH, whether it occurs or not. All of the above? Or none? All, okay. Again, reversibility in IHH, TAG3, TAG receptor 3, patients with micropenis, cryptorchidism. Yes, Rajada talked about micropenis and cryptorchidism. Pascalini syndrome, all of the above, none. None is the answer from the floor, and my chairpersons, please. Okay. Relapse and re-reversal. So we also have relapse. We have from this it is clear that we do have reversal. Patients can also have relapse going to in the hypogonadism state after having a reversal. And re-reversal has been linked with weight loss. These people are very sensitive to lifestyle, including psychological stress and all. So the answer, I think it's very easy now. So from here we start with our topic in proper. So IHH is characterized by isolated gonadotropic releasing hormone deficiency resulting in absent and insufficient puberty and infertility. So we are talking about the androgenism part and the fertility part. Traditionally it was considered irreversible, but growing evidence suggests otherwise. So these are the elegant studies, reversal of IHH, clinical studies. Recent paper, it was an editorial in the paper which had this article by Doyer et al. And he has shown 36%. Remember the quiz in patients with Pascalini syndrome. Initial papers were there with Revio. Look at the percentage, 33%. And Sidhum's paper, all of us should go at least once for this, citing 16%. We had a mention of 5%. Sudipda is not here. In the endocrine textbook 2015, he has his own personal communication, and out of the 50 patients, 10 patients were having anosmia, and out of the 40, 2 of them had gone into reversal. So that comes to 5% of the normosic patients having reversal. I don't know whether Sudipta remembers by himself or not. It was there in the endocrine textbook 2015. So 10 to 20% was the editorial unavowed, and this is the overall reversal rate, and different series citing different percentages from 16 to 33%. And Pascalini syndrome, this is the fertile eunuch syndrome, and definitely these people, they do have normal spermatogenesis, and with reduced LH activity, less testosterone activity, so the androgenism part is less in the phenotype. Continuing with the Dyer paper, normalization of HPG axis happened after 18 years of age. Mean duration of hormonal therapy in them was to the tune of 7 years, and 30% of men with reversal had mean sperm concentration of more than 15 millions per ml. Reversal, they had categorized into 2, the reversal class, which was 2, and you can see 12 of the 89 patients were falling in this class. And 83% class 2 Pascalini syndrome patients had detectable FSH and combined testicular volume of at least 8 ml. So these 2 parameters, the detectable FSH and combined testicular volume, definitely they do favor reversibility, and 83% of these reversible patients were falling in this category. I have put in the yellow anosmia, cryptorchidism, low serum testosterone, combined testicular volume less than 4 were more towards non-reversal. But I would highlight, it is being highlighted because these category of patients do also show reversal, including the typical Coleman syndrome, which is also X-linked. So reversible predictors, patient who enter spontaneous mini-puberty, and this is a very important area. Rajada talked about mini-puberty, and the importance is that if you encounter and you are able to treat these patients with the SCG, you are doing a dual effect. You are increasing the testicular size, and you are aiding in the testicular descent in patients who are having cryptorchidism. And there are studies, there are no studies linking intervention in mini-puberty and having its effect after puberty in patients with IHH. But what is mentioned is the testosterone levels during mini-puberty has been shown to be linked with the sperm concentration after puberty. So from there, this important entity is there. Otherwise, we can well guess patients with partial puberty at diagnosis, young adult onset, and definitely with the testosterone more than 100. Baseline inhibin B, this is a distinguishing feature with CDP and IHH of more than 65 picogram per ml. These people, they are good predictors for reversal. Again, I have highlighted cryptorchidism, micropenis, the absence of these, normosmia, mild hyposmia, and no syndromic anomalies. Definitely, they would favor reversal. But as I said, these phenotypic features are also been linked with, has been linked with reversal. So patients with anosmia, patients with syndromic anomalies, and patients with cryptorchidism, micropenis, you will see in the next slide how patients with these two conditions also have been linked with reversal. And definitely, I showed you in the previous slide on Pascalini syndrome, detectable even low FSH and detectable LH, good LH response with gonadotropins have been associated with reversal. These were the initial studies, IHH reversal relapse criteria, and the initial part you can see, the diagnosis of IHH and the relapse. These patients were having testosterone of less than 100 nanogram percent, estradiol less than 20. And about the LH, anybody's guess, they will be having either a low or normal LH response. Now in the reversal, you find a mention of testosterone more than 250 nanogram percent or more than 150 with normal semen production. So these are two very important aspects when you are stopping the ongoing therapy. An ongoing therapy in the Revio group, it was SCG or gonadotropins. And in the another study, Rajesh is not here, it was from Amini's ma'am time in 2013, and they had a very interesting paper. They observed patients after 18 years of age, and the category of patients were having testicular volume of 3 to 6 ml. And there they started with testosterone injections, 250 milligram every 3 weeks, and they continued till the testicular volume went up to 10 ml. Just imagine, we all know that if you are giving testosterone from outside, there will be regression of the testicular volume. But in these patients who are diagnosed as IHH and instituted therapy after 18 years of age with testosterone, 250 milligram every 3 weeks, and till they attained 10 ml testicular volume, and then the treatment was stopped. And they had found the reversal, and interestingly, they are all corroborating with the international literature. Out of the 9 patients they studied, 2 were having testicular volume above 15 ml. That is Tanner 5. Tanner 4, it was 10 to 12. And almost 6 patients, they had testosterone levels above 300 nanogram percent, and the rest 3, they were having more than 150, but all of them showed normal seminal parameters. So you see the definition which was there in the Sidhum's group 2013. It was similar what they have observed in the study by Rajesh Khadgawat and Dr. Amini Man's study that was again in 2013. And that paper of Sidhum was in 2013. So testicular volume, the reversal again, if it exceeds 4 ml or there is more than 2 ml increase in the absence of gonadotropin releasing hormone or gonadotropin therapy. And I would like to mention off therapy is for gonadotropin releasing hormone therapy, it is to the tune of 4 weeks, and for injection SCG and testosterone, it was taken as 8 weeks. And this study of 150 testosterone and seminal parameters, they were off therapy for 6 months. So different studies had these different cutoffs of therapy. And in the smaller things, you will find mention about the LH pulse frequency and the LH values, which were again showing a normal response in the reversal category. Similarly, we had in the females. I won't go into the details of the female part due to shortage of time. This is the genetic study, and as you saw, it was nicely shown by Rajada. KEM study have done elegant work on this one, and almost 50% of the patients of IHH can be explained by genetic mutations. And interestingly, you will see an overlap of the genetics in the anosmic type and the non-anosmic type. But it is important to realize, which is there in the next slide, that the patients who had reversal, they were particularly falling under that KNDY stage you saw in that slide shown by Rajada, how they were affecting the olfaction part and the migration part of the neurons. And the neurokinin pathway, the mutations which were there in the neurokinin pathway, KNDY, they were showing more of reversal rather than those who are typically linked with the olfactory preclude. Now, genetic mutations, now it has gone to up to 50%. So the autosomal dominant or sporadic forms, and this is the FGFR1, prokinetic receptor 2, and gonadotropin releasing hormone. And out of these three, it is important to mention in the normosemic category, the maximum percentage is there with FGFR1. This is for the international, in the Caucasians. In the East Asians, it is PROC-R2. And in we Indians, again KEM data, it is primarily by the gonadotropin releasing hormone gene mutations. And definitely cases with non-null mutations or hypomorphic alleles, they will be more linked with reversal. Null mutations, definitely they will be on the severe part. Now, neurokinin B signaling genes, as I told you, TAG3, receptor 3 are more linked with the reversibility, and 83% reversibility in TAG3 and receptor 3 cohort has been shown by Giannetti et al. Micropenis and cryptorchidism has been linked with the TAG3 mutant variant. So this is just to highlight that even in this severe phenotypic category of cryptorchidism and micropenis, we can have reversal. Okay, and again, the highlighted part, anosmine 1 gene mutation, they lead to null or severe loss of function mutations, and this is the permanent phenotype of Bowman's variant. But again, I told you, Ribeiro et al. In 2016, they have reported reversibility even in this severe category of X-linked CAL1 gene mutation. These are two of my patients, and just have an intense look. These are normosemic, autosomal dominant, IHH. The smell was definitely a subjective one. And two different category of patients, almost similar age, you see. The chronological age is around 13. And look at the weightage of both the patients on the higher side. And the first one is falling under the hypogonadotropic hypogonadism, and the other also the same category, but showing features of reversal in the form of onset of puberty. And as you see in the prepubertal part, testicular volume, stress penile length, basal LH, basal testosterone, and post-SCG all on the lower side. And the other, you see increase in testicular volume, increase in stress penile length, and despite that, you see in the basal testosterone 9 months ago, it was similar to the first patient. And this is just to highlight that despite these two genetic mutations, we are seeing that in this age group of 13, the patient is entering puberty. What to talk of 18 years? And the question would come to mind, why to go for genetic tests? So I think if you are able to show that this patient will be entering the reversal part, it will be so reassuring to the patient party. And this patient we are seeing entering puberty, he has received testosterone injections for microphallus in the past. And we will see in our subsequent slides how, as we saw in Rajesh Khadar's paper, testosterone therapy can impact the pubertal onset in this category of patients. So that is the interesting part of this LGR4. It is a very less common genetic mutation, and this is leucine-rich GPR4 receptor. And just to give you an idea, we have the LGR1, which is FSH receptor. And the 2 is LH, and 3 is TSH, and 4 is this one. We have 6 of such, and coming under, according to the hinge molecules, falling under ABC category of this G protein coupled receptors. So this patient's very rare mutation though. And this slide will give you a glimpse of what we are talking about and the mechanistic part. So I will go just one by one. So LGR4, G protein coupled receptor, it regulates the WNT beta-catenin pathway. Normosemic patient, mostly missense or hypomorphic mutation, autosomal recessive, sometimes dominant, and impaired WNT signaling. There is defective gonadotropin releasing hormone neuronal migration. Okay? And reported in reversible IHH. Then we have the residual receptor function, sometimes dental anomalies and low bone density. And interestingly, this mutation has been linked with weight loss. It has been seen that this mutation is linked with reduced subcutaneous tissue and increased energy expenditure. And along with that, they may have some dental anomalies and gonadal defects. And you can see lower down, modifier genes on environmental factors, metabolic environment, androgen exposure can impact the clinical course. Reversibility characteristics, post-pubertal reversal after androgen therapy or spontaneously. So this patient is in the prepubertal stage, but the same follows in the patient who has already entered this. So this is IL-17RD, and here you find a mention of SEF. They are similar to FGF1. So this IL-17RD is similar to FGF action. And here also autosomal recessive or dominant, dysregulated FGF signaling, reversibility, yes. And interestingly, again, you see non-null alleles may occur with other development anomalies. And lower down, you see the other IGF pathways, gene interactions can impact the clinical course, and reversal reported in late adolescence or adulthood. But I would like to see the other side also. It is similar to reversal from androgen therapy. And as I told you, this patient received multiple injections of testosterone for microphallus. And possibly this could have linked to an earlier pubertal onset in this category of patients who happen to have a delayed puberty. Now, possible mechanisms, delayed maturation of gonadotropin releasing hormones, environmental factors. I told you these patients are possibly more sensitive to these insults of body weight and the insulin resistance thereof. Epigenetics, plasticity are involved over there. And important is the last part, hormonal treatment. Priming of gonadotropin releasing hormone axis and testosterone, estrogen, they can activate kisspeptin, they reduce inhibitory methylation, affecting the macaron pathway, or enhance synaptic input by stimulating the dormant gonadotropin releasing hormone circuits. Now this is the, again, the reversal going into relapse, triphasic pattern. And this is the relapse rate. You can see in the Sidhom's group, 11%, linked with weight loss. And the role of obesity, everybody knows, acting through the leptin pathway, estrogen and inflammatory cytokines, suppressing the gonadotropin releasing hormone axis. The other stressors, chronic stress, starting with anxiety to frank depression, can impact the gonadotropin axis. Undernutrition, weight loss, sleep disorders linked with decreased testosterone, EDCs, kisspeptin, they can all impact the pubertal onset in this category of patients. The important is this, with the likelihood of reversibility, which is definitely there, we should consider supervised treatment withdrawal, monitor LHFSS testosterone inhibin B every 3 to 6 months, and important is for the reversibility part, contraception in that promiscuous group is important, and sperm banking is again important for counseling in patients who are having a potential to go into relapse. And from here, I think everybody would give the right answer. Once again, reversibility in IHH. From the chairs, you have to lead the audience. It was all of the above, 5% normosemic, Sudhir Chatterjee's group, 10 to 20% males, few females, anavult, editorial, 18% Pascalini syndrome, fertile eunuch syndrome. They do have less of LH, normal FSH, good testicular volume, more than 8 ml. So this is again all of the above. Some answer was there from the back. Reversibility in IHH, I told you even in typical Coleman syndrome, X-linked, we can have reversal. Definitely there with FGFR1, the PROCARD2, the gonadotropic releasing hormone, they have all been limiting the reversibility, and particularly the genes which are involved in the neurocanine pathway, including TAG3 and TAG-R3. I told you this has been linked with micropenis and cryptorchidism. Pascalini syndrome, definitely almost 83% were falling in that reversible category. And relapse and reversal, I showed you a relapse in the Sidholm's class, and out of these, one had re-reversal with weight loss, and we know the impact of obesity on the gonadotropic axis. So thank you all for the patient hearing.
Thank you very much, sir. Questions, if any, we'll take two, just the last two. Any questions from the audience?
Can you tell me the simple morphological features by which we can say that this patient can have chances of reversibility?
Biochemical, I showed you those patients having detectable, although low FSH values, and a good testicular volume. In the Rajesh Khadgawat group, they had included patients with 3 to 6 ml. So they were not typical hypogonadism. Possibly they were having patients with Pascalini syndrome. They didn't have that analysis at that time. But with that testicular volume on the higher side, entering those signs at a later age, partial pubertal signs, definitely they had all their patients with P2.
Yes.
So that is a marker. Testicular volume and a detectable FSH value is more in favor of reversal.
Thank you.
Sir, I have a question. Sir, how does testosterone therapy help in this reversal?
Okay, I showed that. Can I have the slide? Okay, David. Just imagine two scenarios. Patients with CAH, 46XY, and they have been linked with precocious puberty. Second is in patients with constitutional delayed puberty, we give testosterone, and it has been shown to give that spurt of pubertal onset. Mechanism, as I showed you, their effect on promoting the kisspeptin pathway, the inhibiting the epigenetic pathway, which is acting on that macaron pathway, and lastly, their direct effect on the synapticity of the neurons, which is termed as plasticity of the neurons. So all these three reasons have been put forth for the effect of testosterone in puberty.
So testosterone we should give before even trying for HCG, means for increasing the testicular volume, generally we go for...
I emphasize on this point. Whenever we give testosterone, we know that it will produce testicular regression, the volume will be reduced. And interestingly, when you are treating patients with this category, suppose a patient with IHH, we don't continue. Initial period, it is now said that preferably it should be with SCG to increase the testicular volume to have good effect later on when the patient is planning to have baby or for the later on period, and then only institute testosterone therapy. So testosterone therapy is the basis of treatment of hypogonadism, be it hyper or hypo. And in this patient, in the series of Rajesh Khadgawat, they had continued that testosterone in those category of patients of IHH. They were on testosterone, and they continued that. Anyway, they would have continued with testosterone therapy. And in the patients category who achieved increase in testicular volume, they had this observational data. So this is that interesting. Patients with IHH on testosterone, If they are having increased testicular volume, you will definitely think that there is something else and you will be positive from that angle. And that is the reason why when you are thinking of reversibility, it is important to stop the treatment and assess what I showed you, LH versus testosterone in NB.
So thank you very much, sir. We have come to the end of the session. Thanks to both speakers for fostering an excellent discussion. And with that, we would like to say goodbye. Thank you. Yeah.
Thank you. Thank you, chairpersons and speakers, sir. So we come to the end of the session today. The valedictory and award session will start in this hall from 1:45 p.m. So please be seated.
2.5 days, and if you include the pre-conference workshop as well, we have exchanged ideas, we have discussed groundbreaking research, we have made collaborations, and we'll reflect briefly on what we have achieved over the last 2.5 or 3 days and how we are going to look forward in the future. So let's make it a memorable grand finale closing ceremony. I invite on the stage the organizing chairperson, Dr. Kaushik Pandit, the organizing secretary, Dr. Sujoy Ghosh, and the scientific chairperson, Dr. Pradeep Mukherjee. We'll first have a keynote address from Dr. Kaushik Pandit. We then have the award ceremony, which is going to take some time because we have 48 awards in orals and posters, as well as the quiz awards to give out, followed by the concluding remark by the organizing secretary. Sir, oh, we have our patron, I missed it, sorry sir, Professor Shubhankar Choudhury as well. Sir, if you can please come on the dais. I didn't see that you were seated here. Sir, please. So I would then request Professor Shubhankar Choudhury to deliver a keynote address as a reflection on the last 3.5 days or 2.5 days of the conference.
It's been a wonderful opportunity for us. I hope the delegates from across the country, the faculty from across the globe who participated were equally happy. There must have been some blemishes which we would definitely like to rectify. And it's a great experience with so much of promise shown not only in academic field by people from across our country, but also in terms of organizational skills that were shown by our very excellent organizing committee. A big hand to the organizing committee. I'm sure we'll have more opportunities in future as well, maybe another 15 years from now, and I'm sure we'll put up an even bigger show in the days to come. Thank you very much.
So I'd request Dr. Kaushik Pandit to share some of his keynotes, and then I'll go to the audience as is customary in any valedictory session to get your feedback for the conference.
Good afternoon. I'm indeed thankful to have been endowed with this responsibility of organizing chairperson, and thankful especially because we had an excellent team for the conduct of this great conference. This is not the time to bid adieu. This is not to say goodbye. Rather, it is a time to reinforce our relationship amongst ourselves. This is a time to reflect on the fact that we have learned many new things in the last 3.5 days. Probably it has made us richer. It is also a time to look forward to the activities of the ESI, which is once again going to reach the height in the October 2026 as ASCVD 2026 in Chennai. As organizing chairperson, I'm not here to take the credit, but I would request from all the delegates and faculty how we can improve ASCVD further. So whatever blemishes or whatever drawbacks that you have noted, kindly let us know so that we can have a better ASCVD next time. And as President of the Endocrine Society of India, it is my request to all of you, to all the members, please send us suggestions how we can be a better and responsible organization in the country, contributing to the betterment of our patients, our science in this country. So with this, I would thank you profusely for being here and made this one as a successful conference. Thank you very much.
So we have had close to 2,100 unique batch scans, or in other words, more than 2,000 individuals have attended this conference over the last few days. But for expected reasons, we have possibly less than 200 people in the valedictory session today. But I would request all of you, if any of you have anything to say regarding anything bad especially, and if you have something good as well to say, please use the microphones which are there in the aisle.
One word, enjoy being here. Academic feast was there. It is, you know, when you organize such a big conference or a marriage, things have to go wrong somewhere or the other. If it didn't, then there is something wrong with us. So we should overlook all those things. So overall, how it went is what matters. And there were, I am sure you must have had a lot of logistic issues in getting people on time, finishing papers on time, and so many other things. In spite of that, I had a very good time. One of the reasons we come is not only for academic feast, but also to network with all of you. We invariably see you once in a year for 2-3 days. So it is very nice meeting all of you and improve our talking to each other, talk about our life and other things also. So all in all, I think it was very, very good. Thank you.
I have thoroughly enjoyed the conference, and I think one or two suggestions which I had given to our secretary had been met with, so I think I'm quite happy with the scientific sessions and the discussions that took place, and I'm very, very grateful to all of you. Thank you very much.
The leaders of ESI here. This is a privilege being in the valedictory function. Though I came a little late, doing a 4 days long program, 4th, 5th, 6th and 7th with almost 2,000 plus people is not very easy, as we know. And I have enjoyed yesterday's meeting, yesterday's dinner, and also today's scientific program. Everything is flawless, as usual, Bengal style. So I liked the science, I liked the food, I liked the ambience, I liked the fellowship, and please give a big hand for the leaders of Endocrine Society who have not only did it very well, but a series of leadership from the soil of Bengal has shown the exemplary leadership in the country and beyond. And we are especially very excited to have an opportunity of hosting the conference in 2027, which started from here. So this will be a memorable event for all of us. Thank you. Thank you. Dr. Srikant sir.
Hari Om, Hari Om. First of all, thanks a million. It was wonderful. I'll start, I have not prepared 1 or 2 points. Sujoy and his wife, with somebody going to get the Durga Mata there, it summarized for me how much minute details they have taken to reflect the, all SECons are good, and this was really superb. And everybody, minute details, the young to the old. The scientific program was so good. I'll be turning 70 this Diwali. I was making up my mind. I'm not going to attend any more international conferences, but I want to attend every SECon. The way you have done, the quality is as good or better, right from the registration counter, the poster things, still they are sticking up. It is more than world standard. Thank you. Science sessions were very good. Marwa ji is there. Myself, Marwa, belong to the intermediate generation. Professor Ahuja would be blessing all of you from the heaven, along with Rastogi and everybody. He would have loved the Endocrine Society used to have 20 people. We would meet in a hall. Hats off. It makes you a proud Bharatiya. Hats off to West Bengal team. Thank you very much. Science was excellent.
Thank you, sir.
Thank you.
Now, yes, sir.
One suggestion, I was getting lost in this place. If there could be arrows marked for where the lunch is for faculty, I think that would be great.
So we need to have a smaller space now. Okay, can you have a different sort of ideas from a different angle? Can I ask from the industry, Mr. Shibu Nair, I've seen him, so could you please reflect upon?
Thank you, sir, for giving me this opportunity to, definitely when you ask for a feedback, you need to start finding out reasons what I would say different from the rest of the people. But essentially, I have been here for last 3 days. One, the choice of place for any doctor to come here and attend the session was excellent. I haven't heard any of the doctors who have come from outside give any other remark than what most of the people have said. But yes, there are areas which everybody looks at it from an improvement perspective. Maybe I would have expected more people to come and be here at the end, but nevertheless, sir, it was wonderful to be here.